Hola, me llamo Jenny, and that is about as much Spanish as I've got, I'm afraid, guys. So the rest will be in English. But welcome to the Nursing Symposium of the 49th ISPN uh, conference. And it's great to have everybody from around the world joining us today. We've got some amazing talks going on. We have some fascinating talks from all corners of the world, from nurses, and we have three invited speakers as well who are going to talk to us about a really wide topic as well. Just to let you know that we do have an award this year for the best presentation. And myself and a couple of other people will be looking out during the day to see who is the best presentation. The person who gets the award for the best presentation will get a very fancy certificate, and also will have their registration paid for next year's conference in Toronto. That's the 50th. It's going to be a very big celebration. And we very much look forward to having a really large contingent of nurses on the actually at the conference next year. So please put it in your diaries. It's the 12th of October next year, 2024. So that's very exciting. I'm Jenny, and I head up the nursing committee at the moment. I have one more year to go. We have quite a lot going on, and we would really like some other people to join us. So if anybody would like to join the committee, please just send me an email. My email will be on the site for people to be able to see. If you'd like to join us, we meet about every 6 to 8 weeks, and we meet via Zoom. And we will be planning to do 3 or 4 webinars next year. We are working towards having some nursing input in the guide, which is the education part of the ISPN website. And we're working towards having a fabulous conference next year. So please feel free to email me if you would like to be a part of what we're doing. And now I think it's time to kick off. We've got Allison Roberto Da Silva, and he is working in Sao Paulo, in Brazil, and is going to speak to us on the challenges of pediatric neurosurgical nursing in a Brazilian public hospital, the paths of the United Health System, from diagnosis to post-surgery. So Allison, thank you so much for joining us. And I will pass over to you now. Thank you.
Thank you so much, Jenny. It's amazing to meet with you one time. Good. Good talk. What's the challenge of pediatric neurosurgery nursing in Brazilian public hospital? The path of the public health system from Brazil, from diagnosis to after surgery. Good. I have no overlapping interests. The outfit of this talk is talk about presenting the Brazilian healthcare system for all, understanding the path of the patient in the Brazilian unified health system, and show the results of our hospital, a large teaching hospital in the state of São Paulo, Brazil. Good. In the 17th and 18th, several groups of Brazil engaged for the health movement, with the aim of thinking about public systems to serve the population with no costing in defending a universal right to health. The law of SUS, Unified health system has signed in the Brazilian Parliament on September 19 in 1990, and including in the constitution of the country. The Brazilian Unified Health System is one of the most complex and comprehensive public health systems in the world, and it can cover all the country. It has 3 pillars of support: universality, welcome and guarantee health to all without exclusive distinctions; equity, offer care according to the individual needs and each user; and integrality, recognize the patient as a whole and promoting care beyond the health area. Good. However, for the system to be organized in the second wide and plural country, the system has to be worked in regionalized way. And the solution of this is decentralized the health systems, and management responsibilities is divided between the union, states, and municipalities, each with different responsibilities, observing the constitutional and legal determinations that support the system. And we divide the country in regional health districts division. This is the São Paulo states with 16 health district divisions, sorry. The system is divided in 4 stages of care: the primary care, secondary care, tertiary care, and the quaternary care. And the patient walks into the system, and this is progressive, and for all stage is more complexity, nurse care and medical care. Good. The primary care is the set of individual, family, and collective health. This is the primary care. And actions that involve promotion, prevention, protection, diagnosis, treatment, rehabilitation, harm reduction, palliative care, and health assistance. The secondary care is specialized services at outpatient and hospital levels with medium complexity. This level involves care directed towards specialized areas with pediatrics, cardiology, neurology, orthopedics, gynecology, urology, and other specialties. Tertiary care is specialized medical services, diagnostic, therapeutic support, and high complexity care. And this level involves intensive care units, stroke centers units, complex surgeries, specialized beds and nursery, invasive exams, radio interventions, and quaternary care is one station of tertiary. In addition of both services, they include research studies and complex disease, provision and specialized treatments in high complexity. This level are university hospitals, grade center, and institutes of research, and the most complex services on these levels. For the patient to have access to more complex services, such as pediatric neurosurgery, there is a significant part with the single health system. Good. The objective of this talk is to describe the stages faced by the patient, include diagnostics, surgical treatments, postoperative care, and the regular follow-up in the Brazilian Unified Health System. The methodology is on experience report and perform literature reviews of the parts of the United Health System in Brazil for the people gain access to pediatric neurosurgery services in large specialized health centers. Good. We are here in Brazil, and this is São Paulo State, and this is our institution. Well, usually in newborns, the diagnosis is made in the maternity ward. For cases of older children, the family looks of a basic health unit, the doctor refers them to specialized services, and after further diagnosis, the child is references for the tertiary or quaternary services, like our institution here in Ribeirão Preto. In our institution, you have 21 operation rooms for high complexity. Of these, 2 are dedicated for neurosurgeries, 1 for child and 1 for adult patients. This is the example for our OR for neurosurgery. The pediatric neurosurgery services at Ribeirão Preto Clinical Hospitals perform an average of 117 procedures per year, of which 50% are complex oncological cases. We also have one of the largest epilepsy centers in Latin America in our unity, which demand careful attention of the patient care claim, including processes for the first outpatient clinic visit to post-operative care and rehabilitation. This is our rehabilitation center, is an Excel for our hospital, and we have many procedures for day, and this is amazing work to me. 99% of all procedures in our institution is carried of public funding and cover children of all parts of the country. For example, I go to the epilepsy surgeries, and all the countries of the country we have covered in the last years, and we have the surgeries for Paraguay and Portugal too, and the results are good. The results of the institution are excellent, and its specialized teams have already carried and pioneering surgeries in Latin America, like tongue separation. We have 2 cases with success here, and this is our last case, Alana and Maria, separated in the last month. Good. In Brazil, the nurse team are generalists, with specialties that border the medical disciplines. And we have divided in 2 classes of nurses. The registered nurse is a university education, specialization by segments, responsible for the assistance of all the patients, and responsible for the technical team. And we have the nursing technician, is the technical education and executes the care plan created by the registered nurse, and he worked under the area supervision. The nurse team is present throughout the process, from the basics units and the primary care for the most complex surgeries in the quaternary care, and the patient's return to the society and rehabilitation. This is 2 examples, and the basic unity and the complex surgeries. The conclusion of this talk, even with all the difficulties encountered due to the complexity of the current of unified health system, public quaternary health services, Sacree University Hospital of Ribeirão Preto, can keep up with high standards of care due technological advances and the quality of excellence of the pediatric neurosurgical staff. This is my reference, and I will never write a work in regret life. My verse is running water, it's stuck, it's found, it's leaf, and seed, it's life. This is from Karolina, one amazing Brazilian writer. Thank you so much. Muito obrigado, gracias. This is my talk.
Allison, thank you so much.
Thank you.
I'm just asking, does anybody have does anybody have a question for Allison? That was a really fascinating talk. Thank you. And gives us a really good overview of what happens in a large hospital in Brazil. I'm sure we can all relate to lots of bits of it. Does anybody online have a question? Okay, there are no questions at the moment. So we're just waiting for Ashley to log in a second. And then hopefully we can continue.
Recording in progress.
So I'm just going to introduce Ashley, who's here. So Ashley is one of the advanced nurse practitioners in Boston Children's Hospital, and is going to talk to us today on intracranial empyemas related to upper respiratory virus pre and post pandemic. So we're looking forward to that. Thank you. That was really interesting. And I know that we also saw some increase in empyemas post-pandemic, during and post-pandemic. So it'll be interesting. I'd be really interested to know if people in South America or other spaces also have noticed that. Thank you so much, Ashley. And so we will move on to our first invited speaker. Our first invited speaker is Shinuo Liu, and he is a consultant neurosurgeon working in Perth in Western Australia. He trained all across Australia and New Zealand, and did a fellowship in open cerebrovascular neurosurgery in Sydney, which is his hometown. And he is joining us from Australia late in the evening to give us our talk. He also has other specialty interests in CSF disorders and general neuro-oncology. So Shinuo, thank you so much for joining us today. And you're going to talk to us about common open procedures for stroke in children. Thank you so much.
Thank you, Jenny. Can everyone hear me okay? Take that as a yes. Yes. I live in a very remote part of the world, and so sometimes the Wi-Fi is not that reliable. So what I'll do is I'll share my screen and take it from there. All right. So thank you for inviting me to give a talk on something that I'm very passionate about. So this is me, a very heavily photoshopped picture with the background being the Sydney Harbour Bridge. That's my hometown. I currently live in Perth, Western Australia. So I've only been here about a year, and I guess I'm still a bit of a tourist. And so I Googled Western Australia, and this was what I got in the image results. So as you can see, Western Australia covers about a third of the landmass of Australia, and we have 3 million people out of the 26.5 million people in all of Australia. It's a beautiful state with just dramatic landscapes, lots of beaches. I haven't been to very many of these places yet because I've been so busy working. And down here is this little creature called, hang on, just the name just escaped me. Hang on, this is embarrassing. Now I can't remember the little mammal. So they're the only mammal found on Rottnest Island, which is a little island off Perth. It's going to come back to me soon. But anyway, it's a huge tourist draw card. So if any of you have an opportunity to come to Perth, then I definitely encourage you to talk to me, and I can point you in the right direction. So I work in Perth Children's Hospital. It's a pretty new hospital with 300 beds, and our department is made of Kylie Telfer, who you might know, our clinical nurse specialist, and 4 neurosurgeons. Head of department is Snikta Saha, Sharon Lee, and I guess my friend Hari Ramakona and I quite like posing. So there you have it, the two of us in one picture. So I thought I'd give a talk on 2 cases that demonstrate really common pathologies that come through the neurosurgery department in the field of cerebrovascular neurosurgery. So the first case is a 5-year-old girl who was previously well and had some very transient left upper limb and left-sided facial, paresthesia and weakness. So when she first came to the emergency department, she had an MRI which was reported as normal, but in retrospect, you can see here on this T2 FLAIR MRI a little white dot which shouldn't be there in a 5-year-old kid, and you can see these little tiny white blood vessels, which is a very sinister sign of ischemia in the brain. So the final thing was that you had these little clusters of blood vessel found in the circle of Willis, which you should definitely not see in a 5-year-old child. So over the next few weeks, she had some more symptoms affecting the upper limbs and the face. And then one day she just came back to the emergency department with severe fixed right-sided arm weakness. And then after further scans, she was started on aspirin. And so the MRI this time showed an obvious stroke in the left hemisphere. And this is between the territories of the anterior cerebral artery and the middle cerebral artery. And the MR angiogram demonstrated severe narrowing of the internal carotid arteries, the middle cerebral arteries, and these little clusters of blood vessels where the MCA and the ACA should be. So she went on to have a digital subtraction angiogram, and that confirmed the diagnosis of Moegamad disease. And so you can see where the middle cerebral artery and the anterior cerebral artery should be. She has these clusters of these diffuse, ill-defined blood vessels. The word moya means puff of smoke in Japanese, and so that's where the name comes from. On an angiogram, these blood vessels look like a puff of smoke, okay? And by definition, Moegamad disease affects both sides of both carotid arteries. And so these abnormal blood vessels affect both the anterior circulation and the posterior circulation. So here the posterior circulation from the basilar artery has sent, sorry about this just keeps skipping. So the and I might have to just pause it there. Slideshow. Okay, hopefully that works a bit better. So the in the posterior circulation, we've got blood vessels that course from the posterior cerebral artery in an anterior direction, which is definitely not something you see in a 5-year-old kid. What is Moegamad disease? So it's a relatively rare condition in the Western Hemisphere, but rather common in East Asia. And it's a chronic, what we call steno-occlusive condition that affects primarily the internal carotid arteries. And by definition, it affects both sides. So over many months and years, it's thought that the narrowing of the internal carotid artery will lead to opening of these small collateral blood vessels, which give the characteristic puff of smoke appearance on an angiogram. And the brain recruits blood however it can from the existing circulation intracranially, but also extracranially, because it's very, very slowly starved of blood. So in Japan, the disease is probably the most studied in the world, and it's thought that the incidence is about 1 per 100,000, and at any time there's about a dozen children and adults living with the disease. This condition affects females slightly more than males, and about 1 in 6 to 1 in 7 patients have a family history. We commonly see patients present in the primary school age and in high school. And once they kind of pass the 20-year mark, then the next time they present is when they're well and truly an adult. So I might just skip this slide. But there are 2 major ways that Moegamad disease can present, and it depends on the age of presentation and to some degree also ethnicity. So classically, Moegamad disease is thought to be primarily a disease of ischemia in children, whereas in adults, the disease is more of a hemorrhagic problem. So the reason why you get 2 types of presentation is you can imagine if the internal cerebral arteries slowly close over months and years, then it doesn't take very long. It doesn't take very long for the compensating mechanisms in the cerebral vasculature to reach its threshold. And so after a particularly hot day or after a marathon, then it's very difficult for the brain to perfuse all its parts. And so the ischemia that happens is usually in the parts of the brain that are least well perfused. So that typically is between the territories of the middle cerebral artery and the anterior cerebral artery, what we call the border zone. So that's something that happens a lot in children. In adults, the collateral blood vessels, the puff of smoke blood vessels, are thought to transmit some really high blood flows, and so the delicate constitution of these blood vessels means that you get this increased risk of hemorrhage in those areas. So often adult patients have bleeding deep in the cerebral hemispheres. So when we encounter patients with Moegamad disease that is either incidentally found or they have some very vague symptoms, it's often important to not only confirm the diagnosis with a cerebral angiogram, but also to assess what we call the cerebrovascular reserve. So the cerebrovascular reserve is the ability of the brain to compensate for a blood pressure drop. So in normal patients, when there is a hypotensive challenge, okay, so for example, after running a marathon or when someone's particularly dehydrated, the brain is able to increase the cerebral blood flow, okay, as a compensatory response. But in Moegamad disease, because the brain is already maximally compensating because of its chronic ischemic state, then any further challenge is going to be very difficult, okay, for the brain to increase the cerebral perfusion. So we can measure this phenomenon using a variety of imaging modalities, but starting with PET scans being the most expensive and probably the least widely available, but probably the best test, all the way down to Doppler ultrasounds, which are probably not very sensitive. So at our institution, we like to use a SPECT CT scan and challenge the patient with a blood pressure pill, Diamox. So at baseline, you can see that the orange bits are areas of decent blood flow to the brain. Okay, so these are coronal sections of the brain. You can see this is the right hemisphere, left hemisphere. Okay, and the amount of blood flow is quite symmetrical. Okay, when the patient's at rest, but when Diamox is administered, then there is there is a reduction in the amount of orange, so a reduction in the perfusion of the right hemisphere. And so this is unusual, because what we should be seeing is either preservation of the orange or even intensification of the blood flow, so it becomes red. So this is what we typically see in Moegamad disease, or at least symptomatic Moegamad disease. So how do we treat these patients? Firstly, Moegamad disease is a fairly aggressive condition in children. When patients survive to adulthood and beyond, so for example, if they present in the 50s or 60s, it can be argued that the patients probably survived the natural history of the condition if they've not had a stroke or a hemorrhage. But in children, the risk of hemorrhage is the risk of ischemia is quite high. And so treatment is typically, quite aggressive. And so the point of treatment is to A, prevent future ischemia, and B, there are some pretty good studies coming out of that have come out of Japan, proving that patients who are conservatively managed with Moegamad disease have lower IQ points and poorer academic performances as they go from early primary school to adulthood. And so there's a cognitive component to treatment of Moegamad disease. So as with all complex conditions, the treatment is separated into the conservative or non-surgical options, and that's typically mainly centered around aspirin use. Okay, so an antiplatelet. There are some some authorities that, who believe that calcium channel blockers might have a role to play. But essentially, there aren't many options in the medical side of things. And so then it comes down to the surgical options. And this table shows that there are many different types of operations we can perform for Moegamad disease. The whole point of it is to increase blood flow to the brain that is chronically starved of oxygen. So this is a concept called cerebro-revascularization. And roughly speaking, there are two ways we can provide more blood flow to the brain. We can directly anastomose a blood vessel from the scalp to the middle cerebral artery, or we can indirectly cause blood vessels from outside the skull to grow onto the brain, okay? And there are many options for performing these indirect anastomoses. So in our case, and at our institution, we like to perform direct anastomoses or STA to MCA bypasses, okay, where possible. So this is a procedure where the superficial temporal artery, an artery of the scalp, is harvested, kept intact, and directly rerouted to the surface of the brain to be directly sewed on to the distal, to a distal branch of the middle cerebral artery. Okay, so these illustrations demonstrate how this is performed in 7 panels. So harvesting the blood vessels of the scalp, so here is shown right here, performing a craniotomy and exposing the surface of the brain. This is the superficial temporal artery that should be kept intact. And then under high magnification, creating a little stoma, okay, on the middle cerebral artery, okay, preparing this recipient blood vessel for the superficial temporal artery. And so you have blood traveling from the scalp directly, into the brain. So this concept is called flow augmentation, okay? And so this is an alternative, okay, to the STA-MCA bypass. This diagram here, this shows an indirect anastomosis where the superficial temporal artery is kept intact and is simply laid onto the surface of the brain. Okay, and so over many weeks and months, kind of like planting a seed, the superficial temporal artery will send blood vessels onto the surface of the brain, but the process takes time. Okay, whereas in the direct anastomosis or the STA to MCA bypass, there is instant blood flow from the scalp onto the brain. This process requires a whole host of reactions at the molecular level to occur, so that little blood vessels are formed from this big branch onto the cortical middle cerebral artery. So these 2 cartoons demonstrate what I've just described. This is an indirect bypass, okay, and this is a direct bypass, or the STA-MCA bypass. You can see that the blood flow instantly increases as soon as the bypass is switched on, and then over several months, the superficial temporal artery enlarges considerably, okay? Whereas the indirect bypass, you've got this very slow increase in the cerebral blood flow, okay? So the difference is time, okay? There are some authorities who believe there is definitely a superiority of one technique over another, but I think that's the direct versus indirect, but I think the jury is still out. In children, in pediatric Moegamad disease, both techniques, the direct and indirect bypass, are very effective. And it's very rare for indirect bypasses to fail. Direct bypasses require special training. It's technically difficult, and it probably is associated with slightly higher risks, okay? So I thought instead of boring everyone with more text and pictures, I'd show a video, an intraoperative video of what we do. So this is the superficial temporal artery that's being harvested. That day I drank a lot of coffee, so you can see my movements are quite speedy. Oh, sorry about that. Let's do that again. So this is the donor graft, okay, that's being harvested. So we keep this intact and harvest this this graft with a combination of bipolar and fine dissecting scissors. All right, so after keeping this, after isolating this graft from the galea, we open the temporalis muscle, okay, and then we, as shown before, and then we perform a cranial. Oh, I'm very sorry about that. This doesn't seem to be behaving. Let's try that again. Okay, so this is the temporalis muscle being opened, and then we perform a craniotomy under the temporalis muscle, and here is the superficial temporal artery pulsating away. Here I'm measuring the middle cerebral artery. This is the recipient, and it's about 1 millimeter, okay? In children, the middle cerebral artery can be smaller than 1 millimeter, and in fact, it's not uncommon for a 5-year-old for the middle cerebral artery to be less than 0.5 millimeter. The threshold for performing a STA to MCA bypass, which is what we're doing here, is about 0.7 millimeters, okay? The size of the STA vessel seen here is typically around that size as well. So here I've isolated the middle cerebral artery and preparing it for the bypass. Okay, let's just skip along. All right, here I'm dividing the donor superficial temporal artery. All right, and I'm flushing the inside of the superficial temporal artery with some heparinized wash. And now I'm skeletonizing the superficial temporal artery to what we call denude it, okay? Take all the connective tissue off the outside. All right, so the end product after doing this is a very flimsy looking superficial temporal artery, which is quite common in children, okay? We remove the adventitia and at the very end, we trim off the end, all right, to make it nice and neat and free of any traumatized blood vessel. And we open we increase the opening, okay, of the superficial temporal artery. The next step is I cross clamp 2 ends of the middle cerebral artery with these little AVM clips, okay, so blood can no longer flow through this little segment of the middle cerebral artery. And then I'll open a little hole in this trapped segment, okay? This is all done under a very powerful operating microscope. Took a bit of practice, okay, to learn how to do this. And so this is an opening that I make in the wall of the middle cerebral artery. Okay, so the first step is we put in these little nylon sutures into what we call the heel, okay, of the superficial temporal artery donor. So these are like stay sutures. Okay, this is to ensure that the donor stays on the recipient. Okay, so you throw some simple interrupted sutures. These are extremely fine nylon sutures. They're 10-0, so they're finer than a human hair. All right, so this is the heel being sutured, and this is that was the heel sutured, and now this is what we call the toe. All right, so this is just repeating the suturing. Okay, so we tie a knot. Okay, and after the heel and the toe are sutured, right, we inspect the walls to make sure that we've lined up the donor and the recipient. Okay, and then we start suturing what we call the front wall and the back walls. Okay, so let's skip to some suturing. Right, this is the front wall being sutured. Okay, again with a simple interrupted suture. Right. Oh, for some reason it's come back to the beginning. And so after placing one suture on the front wall, we tackle the back wall, and we put a series of simple interrupted sutures along the back wall. Okay. All right, and so we put 3 to 4 sutures on each wall, and we come back to the front wall. This green thing is a little background that I use to improve the visualization, okay, of the tissue, and to also elevate the operative field, kind of like a stage. Okay, and so after completing a series of simple interrupted sutures, these all take 1 to 2 minutes per stitch. Okay, we cut the last suture off. Okay, and then we take the clamps off, and you can see that blood flows through the middle cerebral artery. Okay, and then there's a clip, okay, that goes on the superficial temporal artery, and we take that off as well. And you can see that the STA is pumping very nicely onto the surface of the brain, okay? And so that's the STA to MCA bypass, a direct anastomosis. All right, these are little bits of hemostatic agent that promote the healing of the outside of the anastomosis. All right, so this an example of a really cool thing that we can do to visualize blood flow through the bypass is indocyanine green. So this is a fluorescent dye that demonstrates, this is another case, but it demonstrates that blood is flowing through the recipient, okay, the middle cerebral artery from the donor vessel. All right, so this patient, 5-year-old girl, ended up having an operation to revascularize her left hemisphere, right, which was uneventful. And then a few weeks later, she had her right hemisphere revascularized with exactly the same procedure. This is the STA that you can see being coursing onto the surface of the middle cerebral artery on the right side. So she had no new neurological deficits and was discharged after 4 or 5 days in hospital for each procedure, and she will remain on aspirin for life. So I've seen her a few times now post-operatively, and she's done very well, no new strokes, and hopefully she will lead a very normal life in the future. Are there any questions regarding case 1? Doesn't look like it. I'll keep going. All right, so the second case is a 15-year-old girl who presented with a very poor GCS and a fixed right pupil. So her CT scan demonstrated a large intracerebral hematoma in the parietal occipital lobe, as well as some intraventricular hemorrhage and hydrocephalus. So after emergency EVD placement, all right, a subsequent scan was very suspicious for a tangle of blood vessels in the area of the hematoma. So it was very likely that she harbored an arteriovenous malformation. So what is an arteriovenous malformation, or an AVM? These two illustrations demonstrates the difference between what's normal and what's abnormal. So in the normal situation, the artery is connected to the vein via a capillary network, okay, where the blood vessels get smaller and smaller, and the blood pressure goes lower and lower as the red blood cells squeeze through these little tiny channels. In an AVM, you have a jumble of blood vessels where the artery directly connects to the vein through arteriovenous shunts, so a direct connection between the big artery and the big vein without an intervening capillary network. And so this, you end up with a kind of like a ball of yarn full of these shunts, okay? And the reason why they're dangerous is because these veins are thin-walled and not used to the high blood pressure within the artery. And so these thin-walled abnormal blood vessels can rupture, and this results in an intracerebral hematoma. AVMs also have other presentations, such as seizures and headaches, but they're far less sinister than intracerebral hematomas. So for this girl, she had ICP stabilization via placement of EVDs. We often, in these cases, see how the patients recover before proceeding to diagnosis and then ultimately treatment. In her case, after a day or two, it was found that she was likely not to succumb to her intracerebral hematoma. And she subsequently underwent a cerebral angiogram, which confirmed this abnormal jumble of blood vessels sitting deep inside her right hemisphere, consistent with a large arteriovenous malformation, fed by branches of the middle cerebral artery and the posterior cerebral artery. So there are many ways to anatomically characterize an AVM, but I guess you could say her AVM was either a limbic AVM or a choroidal AVM. After several weeks, she seemed to wake up and was actually starting to move both sides and, regain consciousness. She was talking. Her GCS eventually became 15. And so she had a series of further investigations confirming the location of the arteriovenous malformation, a large clot, okay, on the lateral aspect of what we call the nidus, the center of the AVM. So there are many different ways to grade an AVM, but as surgeons, we use the Spetzler-Martin grading, which is a grading of surgical risk. And that is a risk, that risk is stratified by the size, the location of the AVM, whether it's in brain that does important things, so eloquence, or non-eloquent brain, okay, such as the right frontal lobe. And of course, the the last component is the venous drainage. Is it deep or is it superficial? The reason why that's important is because deep AVMs are difficult to operate on, whereas superficial AVMs are relatively straightforward. So in this patient, she had, her AVM was at least, 4 or 5 centimeters, perhaps up to 6 centimeters. So it's not very clear whether it was medium or large. The AVM was definitely eloquent, okay? And she had deep venous drainage. So her Spencer-Martin grading was quite high. When the Spencer-Martin grade is 4 or 5 out of a possible total score of 5, then it's typically thought that open surgery is too risky. But there are always exceptions, because when the patient is very young, okay, when the patient has had an intracerebral hemorrhage, and if the AVM is compact as opposed to diffuse, which in this case it was compact, then we can certainly consider resection of the AVM, or at least treatment of it, okay? There are other ways to grade the AVM, and that's based on a radiation or a radiosurgery success scoring system, which I won't get too much into. So the natural history of brain AVMs depends on whether it's previously ruptured. So incidentally discovered AVMs are more and more common these days. And it actually doesn't matter whether the patient is an adult or a child. It's thought that the annual risk of an intracerebral hemorrhage is about 2% for an unruptured AVM, going all the way up to more than 5% if the AVM is ruptured. What I tell patients is that when the AVM has ruptured, there is probably at least up to a 15% risk, in fact, of the AVM rupturing in the first year. Over the next several years, the risk does decrease back down to about, the 4.5 that you see here, okay? But it takes several years. And then eventually, if you live long enough, then the risk of the AVM rupturing again goes back down to 2 or 3%, okay? So there are other anatomical features that increase the risk of an AVM rupturing, but we won't get into that. So the options for this patient included conservative management, and that's something we often recommend for patients with very high-grade AVMs, very difficult and formidable lesions. Surgery is often an option for small AVMs. Radiosurgery is an increasingly utilized treatment option for AVMs that are small and medium-sized. And then embolization of the AVM via endovascular techniques is gaining prominence these days. And what's really common around the world is that we're using a combination of these techniques to treat AVMs. So I'll cut a long story short, but in this patient, she was young, made a reasonably good neurological recovery, and the AVM had already ruptured. And so it was thought that treating the AVM definitively via surgery was a reasonable thing to do. And to help the surgery proceed, I enlisted the help of our interventional neuroradiology colleagues to embolize part of the lesion just prior to the operation. So our INR colleagues sent these little tiny microcatheters, okay, to branches of the posterior cerebral artery to shut down little parts of the AVM, not to cure it, but to reduce the blood flow into parts of the AVM that I would find challenging to get to at the beginning of the operation. Okay, so this is before, and that's after, and you can see that the parts of the AVM has already disappeared. Of course, about 80% of the AVM is still being untreated, but every little bit helps. So this is I'll show you a quick video of what we did. So this is the surface of the brain. As you can see, you can't really see the AVM. This is the interhemispheric fissure. That's lateral. That's anterior, and that's posterior. So I used the fact that this patient's left upper limb had very poor function, and the fact that she had hemorrhaged into the AVM already. So I went through the cortex of the brain. This is brain that is not thought to be very functional, so non-eloquent. All right. And so this is just deepening the surgical approach, going through white matter. And this is, here I've reached part of the AVM. This is just the superficial part of it. You can see this abnormal blood vessel just on the surface. Okay, this is part of the surface of the nidus. Okay, and I'm tackling the front of the AVM. All right, so using bipolar cautery to disconnect these abnormal blood vessels. So an AVM isn't like a tumor, like where you can just chip away at bits of it. The AVM has to be resected all in one go, what we call en bloc resection. Okay, so the idea is we disconnect the arterial feeders, right, on the outside, leaving the venous drainage to the very end. Okay, here this is the front of the AVM, and I'm using the fact that this is old blood, okay, to my advantage, all right, to disconnect the arterial feeders from the anterior aspect. So things are going really well here, all right? But as is the case with big, formidable AVMs, as I kind of go further and further, deeper and deeper, okay, the view becomes more and more challenging, okay? And let's see if I can find an example. I bipolar and cut these arterial feeders, okay, getting good views of the edge of the nidus, okay, this is the rest of the AVM, all right? And then all of a sudden, you can just be minding your own business, doing a really good job, and the AVM just starts hemorrhaging. And it's not the kind of hemorrhage that just settles with a bit of patience. This is, very brisk bleeding. And you can bleed out from, you can exsanguinate and basically die on the operating table if you don't have your wits about you, because the entire circulating volume goes through this little AVM. So there are some tricks of the trade to managing bleeding, but sometimes with large AVMs, you have to just accept that the whole thing isn't as dry as you want it to be. But eventually you kind of get control. Let's skip forward a bit. So we've kind of worked on the anterior aspect of the AVM, and now we're working on the medial aspect. I realized at this point that I needed to increase the surgical exposure, all right, having reached kind of like the limit of the of my operative corridor, okay, through this opening, little tiny opening of the brain, still relatively small. It's only about 3 or 4 centimeters from here to here. And so at this point, I've decided to increase the opening through the brain right to the interhemispheric fissure. So this was where I previously operated, and this is a new kind of opening through the brain to the AVM nidus, and I've just joined the two up. Okay, here I'm now working on the medial aspect of the AVM. This is the falx, okay, and these are little tiny AVM clips that I use to shut down particularly challenging or either large or friable arteries. So the whole exercise is going around the AVM like a cone, shutting down shutting down arteries wherever I go on the outside of the AVM. I'm sorry about the video skipping. And here I've reached a medial aspect of the AVM, but there's still a lot of work to go. Okay, so, and then when you're deep down in the AVM, this is, you know, kind of at the very depth of the AVM, you can still encounter very, very brisk, very challenging bleeding. Okay, from memory, I think this girl only had 2 units of packed red cells transfused during the operation, so surprisingly, I was surprised I didn't need more. And we might just skip forward. Okay, so you kind of go around and around from superficial to deep. Okay, and now I've worked on the medial aspect, the anterior aspect, and this is the 8 parts of the AVM that's within the lateral ventricles, and these are bits of choroid plexus. So this, after working on the choroid plexus, this has allowed me to access parts of the AVM that's really at the center of the skull. Okay, and
Shinuo, I'm sorry to interrupt you, but can you bring it to a close, please? Because the following speaker has to be on duty, and she needs to bring it out. So yes, I'm sorry. I'm so sorry to interrupt.
No, that's okay. So at the very end, okay, I'll show you the end result. This is the AVM all disconnected, and it now is only connected to the brain via this structure right here. Okay, that's the primary draining vein. So we coagulated, all right, put a large aneurysm clip on it, and then we cut the disconnection, and the entire AVM the entire AVM is lifted out, and she's cured. So we proved that she's been cured with a repeat cerebral angiogram. There's no more shunting, okay, from the arteries to the vein. And she's actually done quite well. She's had some challenges, but she's going to be just fine. So thank you very much for listening to my talk. If there are any questions, there's probably time for one, or not really.
I think if people could put their questions, I'm sure people have questions. I have a question that I will put to you, and we will pop them on the chat box, and then you can answer them to people, please. Because I'm very aware that Shani is waiting and is desperately having to go to be on duty. So we're going to go to Shani now. Shinuo, thank you so much. That was really interesting, and I will definitely come back with a question for you later.
Thank you.
Please stay online.
Will do.
So thank you. And now we have Shani. Shani is joining us from India. Shani, I'm not very sure where in India you are, just there. Kerala, fabulous. Welcome. Thank you so much for speaking. And we look forward to your talk about neurorehabilitation. Thank you for joining us today, and I hope you're not late for work. Shani, you need to unmute yourself. Shani, we can't hear you. You need to unmute yourself.
I hope my slides are visible. Yeah, okay. Good afternoon. And myself, Shani. I'm working in as an in charge of neurosurgery ICU of Sri Chitta Tirunal Institute of Medical Science and Technology. It's a hospital, tertiary referral hospital in the farthest end of India, Kerala. That too, again, to Trivandrum.
Shani, can you just make it a big screen, please?
Yeah, just a minute. Yeah.
Fabulous. Thank you so much.
Yeah. Okay. And I have to leave for duty at 7:30 p.m. Indian Standard Time. That's why I'm quite rushing. Anyway, I'll be presenting on neuro rehabilitation by explaining a case study. Neuro rehabilitation is a continuous process in which the treatment program have to be initiated and then constantly revised and updated based on the therapy-mediated improvement of patients, even either in adult or pediatric patients. This neuro rehabilitation program usually aims to minimize the disability caused by the underlying or a baseline disease or surgical condition and helping the individual to adapt to the new situation. And obviously, the neuro rehabilitation is quite challenging in the context of neurosurgery because there may be, in addition to the physical deficits, there may be associated respiratory problems, respiratory muscle weakness that will add to the additional problems which contribute to neuro rehabilitation, a tiresome and tedious process. And this neuro rehabilitation plan should be individualized, and we should have a multidisciplinary team collaboration, and in which the nurses have a pivotal role to play in the management of these patients. A case scenario: my child was a 10-year-old boy who attained all the developmental milestones up to at the appropriate age levels. He was immunized to the age, but he had a past history of operated PDA at the 5 months of his age, but thereafter no disease or nothing specifically related to that condition. And he was apparently normal until he developed the signs and symptoms, which I'll be telling you in the next slides. And he was referred to our center with a diagnosis of cervicomedullary lesion. Not diagnosed exactly what it was. It is a tumor involving the lower part of medulla and upper spinal cord. This was the diagnosis made from the local hospital. And this present illness started 3 years back when the parents noticed that there was a drooping of right shoulder of the child. And later this child developed the tilting of the neck to right side, that is torticollis to right side. Then he had a mild to moderate neck pain that was non-radiating, that too just 1 year back. Referring to our hospital. Then 2 months back, he developed weakness of right upper and lower limbs and changes in his handwriting. And he also had a numbness in his bilateral plantar aspect of his foot. On examination, at admission, he was conscious, alert, and vital signs were stable, and he was in full GCS, and his pupil were reacting, and his size were equal and normal, and his cranial functions were also normal. His muscle bulk and tone were also normal, but he had a slight muscle power reduction in the right side of the body, which was 4/5 compared to left side, which had a full muscle power. And he had a leaning guide towards right side, and torticollis, I already mentioned, to the right side. Now, all his blood investigations were normal. MRI brain showed there is a cervical spinal cord lesion measuring 5 into 1.5 to 3 centimeters. It's a well-defined lesion, and this lesion was starting from the fourth ventricle, and it is extending to the lower medulla, that is the brainstem, and the upper spinal cord level up to C4. And this was suggestive of a brainstem glioma with cervical intramedullary extension. Okay. And syringomyelia is also seen from the cervical thoracic spinal cord up to the corners. This was his image, MRI image. Okay. And what surgery done was a modified suboccipital craniotomy, C1, C2 laminectomy, and C3 to C5 laminoplasty with gross total excision of the lesion. We were thinking it was a glioma, but histopathology examination revealed it was a pilocytic astrocytoma, WHO grade 1, which was in the fourth ventricle and intramedullary cervical spinal cord level. The lesion was in fourth ventricle, medulla, and intramedullary aspect of the cervical spinal cord. And it was grade 1. And it is pilocytic astrocytoma, which has a better prognosis and compared to gliomas. And in the postoperative period, we received the child in our ICU in a conscious state and with stable vital signs. He was on ventilator, but even though we were planning, we may be able to wean off from ventilator. But unfortunately, the child slowly developed the paraparesis postoperatively. That may be because of a medullary dysfunction or maybe due to cord edema. We were thinking we may be gradually able to wean off in few days because this edema will subside. But unfortunately, it did not happen, and the child went for a tracheostomy to aid his weaning and to prevent aspiration and other complications. And now I am moving on to his nursing care aspect. And in this condition, after tracheostomy, child was more or less stable, but not able to wean off from ventilator. And his paraparesis progressed to quadriplegia, but the child was awake. So it was a very horrible condition, and we had to nurse him for 4 months to bring him back to recovery. So what are the nursing care aspects we highlighted to aid his rehabilitation or recovery? The main challenges were to provide his respiratory care in the background of medullary failure, because he has a brainstem dysfunction. Then we have to improve his muscle power and to prevent loss of his muscle bulk, and prevention of DVT, and skin care, nutrition and feeding, especially in the context of pediatric patients. And our ICU was an adult ICU. We often get pediatric patients. We often care for them with some consultations from pediatric specialists, and care of his bowel and bladder to attend to his developmental needs and supporting the family. These are the main areas in which we focused while helping him to bring him back to normal. So in the respiratory care, initially we provide ventilatory support. Not initially, for many months we have to provide ventilatory support. That time we were giving aggressive chest physiotherapy, and in the form of nebulization, and humidified air was given, and we frequently turned, and positional therapy were given to mobilize his secretions, because he has a brainstem and lower cranial dysfunction. So he does not have any productive cough, or even minimal effort in cough. So we have to turn him to provide vibration to mobilize his secretions or to aid in pulmonary toileting. And we provide suctioning so frequently to prevent aspiration and consolidations. In the course of his recovery period, he developed consolidations a few times, but that were treated appropriately with antibiotics as well as proper pulmonary toileting. That contributed to his weaning became very challenging, but gradually we could able to switch on him to support modes, and finally to TPs, and at last we could wean off from ventilator at a period of 4 months. In which we had, with the help of physiotherapists, we taught him assisted breathing techniques like an abdominal breathing, forced expiration. Those things were given to aid to facilitate his breathing. So what other interventions we have done to improve his muscle power include, we have initiated limb passive physiotherapy as early as possible. Usually that is done to prevent further complications, and early initiation will help in adapting and rewiring the neurons by itself, so that the functions of the weakened part can be restored as early as possible. And for intercostals and abdominal muscle strengthening, we had the breathing, forced breathing, and abdominal pressure, and intercostal muscles were stimulated using pulse therapies, and all those were giving to maintain his intercostal muscle strength. And we used braces to promote his musculoskeletal alignment, because he had postural problems. Truncal stability was not there, so we were using braces to promote his body alignment. And foot drop was prevented by using foot support splints. And finally, at the end of 4th month, we could ambulate him to a wheelchair with a minimum trunk balance. And his weight bearing was minimal at the end of 4th month even. And what he did for his nutrition and feeding, we have initiated early rise to feeding, and with the consultation of a dietitian who suggested a high protein and high calorie diet. And we started at 2000 kilocalories of diet with 50 grams of protein, and we started with 1800 ml of fluid orally. And this child had a constant salivary drooling, which created infections in his central line, excoriation of his tracheostomy sites. Lot of problems were there, but gradually how we could solve this problem is that a child was awake, and as he was stable, once he became stable, he is asking for the chocolates. So we used to give small portions of chocolates into his tongue, so that he slowly started swallowing it. So gradually he gained swallowing of his saliva, so the drooling stopped. That itself created his confidence, and he gradually started moving fingers to the whole body. Okay. Then again, we had meanwhile, we did consultation of a speech language pathologist who diagnosed oropharyngeal dysphagia with nasal regurgitation of saliva as well as secretions. But as I told, gradually his swallowing improved and he tolerated semi-solids. But for the initial time periods, we were giving fluids and medications through the trials too. And we were giving stool softeners on a constant basis to prevent constipation. But gradually, to our surprise, he regained his bowel function in the at the very earliest period. But still, he had a bladder incontinence. In order to prevent infection, we removed the indwelling catheter and diapers were using. But meanwhile, we were giving meticulous care to prevent skin excoriations, and he didn't develop any pressure ulcer in the body area. But to our regret, he developed pressure ulcer in the occiput that I'll be explaining later on. And we were using pneumatic compression devices in both his legs to prevent DVT. And of course, we were giving passive exercises and we were turning him every 2 hourly. And we were giving a pharmacological prophylaxis also. And skincare, as already told, we were turning him every 2 hourly, and back massage was given. And daily we were giving bath with soap and water, which prevent his accumulation of exfoliated dead tissues and which maintains his skin in a healthy condition. And we were using head rings and cushions to prevent bed sore, but he developed a bed sore in the occipital region adjacent to the surgical incision. That may be due to he had a persistent torticollis and he was constantly lying down on his right side. But to our surprise, we could heal it at the we could identify it at the very beginning, and we could treat it and we could heal it before shifting the patient to ward. And in order to address his developmental needs, generally to say the child was very cooperative and very friendly, and he was communicating to the staff with lip movements, and he demands for care and favorite foods. So we encouraged his choices, and we asked the family to visit him and support him. But he preferred to stay with our nurses because he was very much friendly with us rather than spending more time with his family. And because he had a long hospital stay. And meanwhile, we educated the family members regarding continuing physiotherapy and follow-up care in the hospital. And his postoperative course was very prolonged, and it takes around 4 months. And meanwhile, this child developed desaturation and cardiac arrest because of medullary dysfunction. At 3 times, he developed a full cardiac arrest, went into asystole, and we could revive him with DC shocks and CPR for around 10 minutes. At times, but he could survive without any neurological or cognitive dysfunction. And in between, he developed illiterate imbalances and acid imbalances. Those were identified and corrected promptly. And we could ambulate him after closing the tracheostomy. At the time of discharge, he was conscious, cheerful, and ambulant to chair, talking and accepting oral feeds. But his muscle power was 3/5 distally, and proximally it was only 2/5. And his bowel and bladder were continent. DVT prevention, physiotherapy, and high protein diet was advocated once discharged, and we advised regular follow-up also. But to tell you that after 4 to 5 months, the child came to OPD for review, walking with his parents, and he came to ICU and meet us, and we were very happy to see him, and he was also very happy, and he remembered all of our name because we give him chocolates by telling our name, so that he remembers us, everyone. To conclude my topic, rehabilitation is of patients with neurological disabilities is a quite long process, and management of child with brainstem dysfunction requires multidisciplinary collaborative team and a nursing staff with the skills to collaborate with the individuals in their care, and other staff can create an environment in which the individual can learn more productive coping skills to assist in their own recovery process in a much effective manner. Thank you. That's about my presentation. Thank you for your patient listening. I think I can, if you have any doubt in this, I can take 1 or 2 questions.
Shani, that was a fabulous speech. Yeah, that's a fabulous talk. Thank you so much. And really, really interesting. I don't know if anybody has a question.
I think they're in the chat box.
They may put it in the chat box for us. I'm just going to ask you one very quick question before we go on to Amalia. Did the child get like post-fossa irritability? Did they get cerebellar mutism symptoms as well?
No, ma'am. He was not at all mute. He was not talking because of tracheostomy. But once he became stable with reduced secretion, he could talk with whispering words. That was due to tracheostomy only. Otherwise, he was not having cerebellar mutism problem.
Lovely. Thank you.
Okay, ma'am. Thank you.
I think there may be no questions so far, it says. Okay. Yeah. Shani, thank you so much and have a good shift.
Thank you, ma'am. Nice joining with you.
Thank you for joining us. So we're going to move on now, and I'm so sorry. I woke up this morning with a horrible laryngitis, so I'm going to squeak at you for the rest of the day. We have our next talk now, and this is Amalia Elkin. Amalia, is that how I say your name?
Amalia Elkin.
Wonderful. And you are going to also talk to us a little bit about rehabilitation and how teamwork is a catalyst in rehabilitation. And Amalia is talking to us from Israel.
Yes.
So thank you so much for joining us today.
Thank you.
And over to you.
I can start. Can I start?
Yes, please, go for it.
Hi. Nice to meet you all. It is a pleasure to virtually be here. My name is Amalia Elkin. I'm from Israel. As you all know, we're time, so I made to disconnect in the middle of the presentation in case of missile attack. In the last 14 years, I have been working as a nurse at the Rambam Medical Center. I spent 11 years working in general pediatrics, and in the last 3 years, I have been working as a pediatric neurosurgery coordinator at the Ruth Rappaport Children's Hospital. The Children's Hospital has 150 beds for kids who need to stay overnight. Every year, 10,000 children come to our hospital. We do 3,000 surgeries each year for different medical problems. We have 150 doctors and 300 nurses who are experts in taking care of children's health. Our neurosurgical unit includes 700 admissions in 2022, 180 surgical operations, 1,200 outpatient clinic visits. Neurological patients have unique challenge. The most common challenge as we see them in our hospital are neurological conditions include many different phases, each with own symptoms and challenge. To help people with conditions like spinal cord injury, traumatic brain injuries, and brain tumors, a comprehensive approach is required. This treatment often involves different therapies, medications, and interventions. It is important to organize and coordinate all these things to create a good treatment plan that works well in the pediatric population. Each patient requires a different approach of treatment according to one's needs and developmental stage. Many individuals with neurological disabilities face additional medical problems because of issues like limited movement, weak muscles, or compromised immune system. Managing these twofold challenges involving cooperating among various healthcare experts. It's crucial to grasp what could potentially happen and take preventive measures before they arise. Neurological disabilities can cause emotional difficulties like feeling sad, worried, or lonely. A well-rounded approach understands how these emotions connect to physical health and start to offer the right support. Parents of children with neurological disabilities often feel very stressed and exhausted. They are not solely concerned about the medical aspect, but often encounter challenges concerning the educational and social aspect of raising a child with a complex medical condition. A complete treatment plan includes help and support for caregivers to make sure both the child and his supporting environment are doing well. Neurological disabilities are often conditions that last long periods of time and require a long-term perspective. It is therefore important to have a treatment plan that is as comprehensive as possible, as predictable as possible, and clear to the parents as much as possible. We understand that in order to overcome those unique challenges, we need a unique approach. Taking care a neurological patient requires more than just one professional. Having a good doctor, nurse, or physiotherapist alone isn't enough. It's about having a team of experts working together. The quality of treatment depends on these experts bringing together their different skills, knowledge, and viewpoint. They work as a team to make the rehabilitation process better. In my presentation, I will explain the important principle behind teamwork and how it helps in rehabilitation. I will show how when professionals from different fields work together, it can greatly improve one's recovery. This way of working together has a name. It is called the biopsychosocial model. The biopsychosocial model of healthcare is all about taking care of the whole person. It states that when we treat a person, we should think about not just their body, but also their thoughts and feelings and how they interact with others. Many studies have shown that what we think, feel, and how we connect with others can really affect how all our medical treatment work. This model helps us understand and manage complex health conditions like chronic disease by looking at all these aspects together. It also encourages teamwork among healthcare professionals and is a way to focus the medical care on the patient. So, in the future, as healthcare gets better, this model reminds us to always think about all persons when we help them get better. As a first step to implement the biopsychosocial model in our work at Rambam Hospital, we established a special team of professionals, each with their own skills and experience. The team includes the head of the pediatric neurosurgery department, a neurosurgery intern, a pediatric neurosurgery coordinating nurse, a surgical chief nurse, a neuropsychologist, a dietitian, a physiotherapist, an occupational therapist, and a social worker. As a team, we work together to provide an integrated care. All team members share the same goal, the well-being and recovery of patients. So let's dive deep a little bit and in a nutshell understand how does this team work. Professor Moni Benifla serves as the head of the goals, a neurosurgical unit. His main role is to lead the team in making decisions and ensuring they are carried out. He guides the treatment process and creates an environment where the team members feel comfortable sharing their insight and recommendations. With the help of a coordinating nurse, he oversees the implementation of the plan step by step. The team develops customized treatment plans for each patient. This involves combining knowledge from various specialist areas to create a comprehensive treatment that addresses all aspects of health, biological, psychological, and social. Once a week, we get at the patient's bedsides and discuss treatment plans that are customized for each patient individually. Additionally, we share insight and make well-thought-out decisions for the continuation of treatment. Involving the patients in their treatment plan improves the cooperative relationship between healthcare professionals and the patient. This enhances the patient's commitment to the success of the treatment plan. Collaboration promotes the sharing of knowledge among team members. Professionals from different fields learn from each other, leading to a better understanding of patients' needs. To conclude, the teamwork we experience here show how professionals from different fields come together and contribute their expertise to create unified and comprehensive treatment strategy, which essentially improves the patient's well-being. In summary, when different kinds of experts work together, it's good for patients. The expert can use their different skills to take care of patients better. This way, there are fewer problems with different treatment plans. It saves time, money, and helps patients get the right care. Also, when the healthcare team talks and works together, they can quickly fix problems and not make patients wait too long for treatment. The multidisciplinary approach, which involves professionals from different healthcare fields working together, isn't just an idea. It leads to better healthcare service. By collaborating, these healthcare experts can improve the quality of treatment and make the patient's life better. Thank you. Toda.
Amalia, thank you so much. That's a really interesting look at what you're doing. And have you seen a change in the outcome of the children now you're using this method of rehab?
Yes. We see, 1 minute. Yes, we see changes, and the patients say why I forget the word.
Don't worry. I don't want to stress you, but I think it's really interesting that you're taking this multidisciplinary approach and that you're getting good results. And thank you so much for sharing that with us.
Thank you.
Okay, guys, so now we're going to take a short break. Excuse me. And we're going to come back at 11:15 to listen to Allison. So it is only going to be a 5-minute break to keep us on time so that the other people who are waiting aren't too late. And we will probably have a slightly shorter lunch break than an hour and come back this afternoon on time. So thank you very much. I'm just going to leave for 5 minutes and then we will be back with Allison's talk at 11:15. Thank you, guys. That'll be the problem. On the correction of complex fetal myelomeningoceles in a large Brazilian public hospital. And this is Allison again from Brazil, from Sao Paulo. Take it away, Allison. Thank you so much.
Thank you so much. Good. This talk is about the antenatal surgical of complex fetal meningoceles in a large Brazilian public hospital. One more time, I have no interest of conflict of interest on this talk. Here, the outfit of this talk is understand the service deployment, the steps for deployment, and the nursing role in this process. For definition, myelomeningocele is a birth defect of occurs when the bones in the spine do not fully form, and primarily is occurs in the early pregnancy. As a result, you observe an opening of the spine in its back, usually in the end of the spine, in the sacral region. The surgical procedures performed during the gestational period have gained strength due to the positive results in treating or improve the clinical conditions and overall survival of both mother and child. Among these procedures, corrections of open spinal dysraphism considerably reduce morbidity and mortality. This is one example in ultrasound exam for myelomeningocele. Good. Additionally, medical literature shows that surgical corrections of myelomeningocele before birth yield excellent results. To ensure the quality and excellence for complex cases, multidisciplinary teams are involved in all stages. And the stages is surgical planning, the surgical procedures, monitoring pregnancy after and before the surgery, the childbirth and postpartum assistance for the mother and child. And for this process, the patient is the center of all actions of the multidisciplinary team. When the anesthesiologist, the neurosurgeon, the obstetrician, and the nursing works together, making the patient the center of all attention. Nursing is present in all stages of the surgical concepts and is fundamental for the success and quality. It's crucial to have nursing care planning throughout all the stages for the success of the procedures and the health of mother and the child. Even in secular country of health reference in Latin America, few health centers carry out these procedures through the United Health System. And this is our symbol of SUS. And we are the 40 hospital in the state of São Paulo make this kind of surgery. The University Hospital at Ribeirão Preto is affiliate of São Paulo University, has made a committed and a major reference center in the region. The objective of these talks is describe the planning and execution stages of challenge faced by nurse team during the fetal myelomeningocele corrections. This is an experience report for the implementation of fetal surgery to correct dysraphism in a large public hospital in Brazil. The results of this. The fetal surgery services as implemented here in our institution in early 2022, and so far we have successfully performed 5 procedures for photocoagulation to correct fetal circulation, and 5 procedures to correct meningocele as made on this kind of surgery, fetal surgery. For the first service deployment, we are here in São Paulo State, in Sudeste of Brazil, and this region of the state is our institution. Your service is a reference for 4 million patients referred by the state health department, and they need a specialized service. During the first appointment with the pregnant, the clinical nurse and the obstetric center creates a care plan based on the necessities of both the mother and the baby. For the surgical stage, the nurse planned the surgical stage based of the procedure. the needs of the surgical teams, and the clinical data found. When the safe surgery is a priority, we're doing up with surgery, and for the SS, we're guided by the ultrasound and intraoperative in OR, you're leaving OR, everything prepared for an emergency birth. And after surgery, we do cardiotocography and ultrasound in the fetus in OR after the end of the anesthetic recovery. Anesthetic recovery is done in obstetric center, not in a recovery center. Good, the nurse team conducted realistic simulations and developed a care plan for the patient considering all nursing diagnoses and these required interventions. In addition, planning is carried with the multidisciplinary team, and the steps were definitive for safety and quality of the procedures, when the patient as the center of the actions. Good. Our first case, surgery was made in 24 weeks of pregnancy, and this is the results. The child birthed in 34 weeks and 1 day of pregnancy without complications. And the 5 children have been born. 3 of these children without any complications, and 2 with hydrocephalus. This one born yet one meningocele. This is another case of without complications, and this is one child born with hydrocephalus and meningocele. For these 2 cases, one was treated with endoscopic third ventriculostomy, and one required one shunting and a new approach for myelomeningoceles. The primary outcome is to positively impact individual lives. This is the child of your first case with your family. Good, because this type of service is lacking in the Brazilian public health system, we rapidly became a reference in São Paulo state. The initial results are promising, and with the service meeting a provision on the filed need, we anticipate receiving numerous cases in the coming years, and we are prepared to handle this surging demand of services. Good, the conclusions is the positive results of fetal surgery for correct myelomeningocele as indisputable. The innovative concept of care substantially improves newborn quality of life, reduces post-birth invasive procedures, shortens hospital stays, and promotes early interaction and family bonding. This is my reference. Thank you so much. It's a pleasure talking to you. Thank you. Muito obrigado. Gracias.
Thank you so much, Allison. That was really fascinating. You're doing some really interesting stuff where you are. I don't know whether there's any questions. I didn't see any on the chat. But please stay around on the chat for a little while longer in case somebody asks a question. Thank you so much for your 2 really interesting presentations today. Thank you. And we will move on. We have the next invited speaker. This is a colleague of mine from Qatar. Dr. Ederies is a perinatal and pediatric neuroradiologist, and he trained both in London and Toronto, and even in Bristol, where I'm from. And now he's working at Sidra Medicine in Qatar. He has a specialist interest in preterm baby injury, having done research at the Centre for Brain Development at Imperial College in London. And I think we're all looking forward to seeing lots of interesting pictures and learning about fetal magnetic resonance imaging. Over to you. Thank you, Ash.
Hello.
Hello.
Hi, can you see my slides okay? Hello.
Hi, Ash. No, we can't see anything. We can just see a blank screen at the moment.
Okay, now?
Still see a black. There we go. We got you now.
Okay, super duper. Okay, so I'm giving this talk on fetal magnetic resonance imaging. The talk was prepared in part with my colleague, Dr. Ashley Robinson, who contributed to some of the slides in imaging. So the layout of the talk would be as follow. Oops. Okay. So oops. Let us go one back. Hang on. Let me just see where I am. Yeah. Okay. So I don't have any disclosures with regard to the talk, nor are there any financial implications with regard to commercial products within the talk. So the layout of the talk would be as follows. Firstly, we'll oversee technical review of the imaging. We'll talk about some fetal urology and then clinical applications of fetal imaging. So the first technical challenge that we have with regard to fetal imaging is the issue of motion, both with regard to the fetus and with regard to maternal factors. Seeing that the fetus is in utero and there is a large cavity filled with fluid, this allows the fetus to move as much as they can, because the amniotic fluid allows for free fetal movement. So in cases of polyhydramnios and a young gestational age, it allows for increased fetal movement. With increasing gestational age, the fetal movement becomes less. And especially in the third trimester, when the fetal head is engaged within the pelvis, there is less fetal movement. And this helps us with regard to acquiring images. With regard to maternal factors, it's important to ensure that the mother is as comfortable as possible, because if the mother is uncomfortable, she will move unnecessarily during the scan. Other maternal factors include maternal respiration, in that the diaphragm is quite close to the uterus, and with breathing it affects the position of the uterus and hence of the fetus, and this can interfere with our imaging techniques. Now we have mechanisms of reducing this, both fetal and maternal mechanism. But before we go through those, we will first talk about the actual imaging of the fetus. Now, indications for imaging includes that there are abnormalities that are seen on ultrasound that needs to be further explored on imaging. This is the most common referral source for MR imaging. In the past, we had imaging on low field strengths, that is at 1.5 Tesla, but with time, there's been an increased move to higher higher magnetic field strengths. This, however, has been shown to be good and safe without any sort of adverse features, both to the mother and the fetus. There were concerns about deficits in hearing because of the excessive noise that the machines cause, as well as the developmental delay in fetuses because of the amount of heat that is absorbed by the maternal abdomen that could be translated to the fetus. This, however, has been not been borne out in long-term studies. Imaging of fetuses these days in most centers are carried at high field strengths at 3 Tesla. And the reason for this is that the contrast resolution is better. And this shows better an anatomic detail of the fetus. As can be seen here, this is at 1.5 T and this is at 3 T. At 1.5 T, there's poor discrimination of the pituitary gland, pituitary stalk. On 3T, you can see the pituitary gland and the pituitary stalk much better. At 1.5T, you can see that there's poor resolution of the anatomical structures of the brain. At the higher field strength, you can see the different layers of the brain. These layers out here are the layers responsible for the migration of the neurons from this end of the brain out to the cortex out here. And this is important if you want to evaluate abnormalities in neuron migration and abnormalities in the fetal parenchyma. The most common sequences we use are T2 beta sequences, and these are T2 beta sequences, as you can see, because the CSF is bright, and this gives an indication of good contrast between the fetal brain and the surrounding CSF space. We use 3D imaging because this helps us to construct multiplanar reformats of a single image you can construct in numerous planes, and it also helps us to process our imaging if you want to do volumetric studies, which will go on further. The other sequences that I use are sort of single shot sequences. Although we can see that the resolution is good, but there are these ocean artifacts that we can see that causes artifacts within the extra-axial fluid and within the ventricles. So most of the sequences we use are these Fiesta, which is heavily T2 weighted sequences. And now, how do we compensate for the ocean that is caused both by the fetus and by maternal factors? These can be divided into three, i.e. preventative strategies, minimization of the ocean that's occurred during the image acquisition. And once the images are acquired, these are corrective actions which can be taken post-acquisition. So with regard to preparation, it's important to make the mother as comfortable as possible within the scanner. And it's preferable to lie the mother on her left lateral aspect, because this prevents compression of the important vascular structures within the retroperitoneum. So most females are scanned on the left lateral aspect to make them as comfortable as possible. Some centers use sedation. Out here, we do not advocate sedation because that interferes in some respect with our imaging. There is some suggestion to advise others not to take caffeine prior to the imaging, because this can cause increased fetal movement. And there's respiratory cating techniques which help to minimize the effect of the diaphragm on the uterus. During the acquisition of imaging, as I explained, we use these fast sequences that you can acquire rapid sequences within a short space of time. We can use ocean resistance sequences, and there's a technique called undersampling, and this helps us to acquire rapidly images within a short period of time. Once the images are taken, we can use post acquisition correctional images, and these are processing of our images. Now, what does this fast imaging look like? This is a T1 weighted sequence. This T1 because the CSF is dark, so that's a T1. And these are the normal T1 weighted sequences. The fast imaging sequences is called a snapshot inversion recovery, which is a fast post-processed image. And we can see that the fetal anatomy is well demonstrated. We can see the fetal ventricles, we can see the fetal parenchyma. And although the images were acquired with a lot of ocean, these images are relatively motion-free. This is the same fetus with a lot of ocean, with poor discrimination of their fetal anatomy. Post-processing with this fast imaging technique will show good delineation of the fetal structures, good delineation of the ventricle system, and good delineation of the orbits. So as I say, the post-processing images have got good diagnostic quality, it's got good contrast resolution. So we can see that if there are any abnormalities within the fetal brain. And other important fast processing imaging is called the Texan images. These are good for looking at sort of hemorrhage or anything that are potentially high signal. These images here are the slow sort of T1 images if you want, and these are the rapid T1 imaging sequences. This is the T1 weight sequence because the CSF is dark. And what we can see in the fast acquired images, this is the thyroid gland, and this is the posterior aspect of the pituitary gland, which is quite poorly seen in the normal sort of acquired imaging. This is the pituitary gland, and you can't see the thyroid tissue. This is intracranially, and what we can see that there's blood within the intracranial compartment, and it can be better seen on these fast imaging sequences. And other fast imaging type of sequence that we use is called the VIBES sequence. These are the standard T1 sequences. And we can see that these poor discrimination of the intracranial contents. On the VIBE sequences, we can see some hemorrhage in the brain. This is the back part of the brain, it's the front part of the brain, and you can see that this area of hemorrhage, this high signal within the anterior part of the brain. And these are best seen with these fast sequences, because with slow sequences, it allows the fetus to move as much as it can and creates all this sort of noise within the system, if you want. These are susceptibility weighted sequences, and with these sequences, we can look at this cerebral blood flow, if you want. So it's a surrogate indicator of cerebral blood flow. This is the front of the brain, this is the back of the brain, and all these black lines out here are blood vessels. And what the susceptibility-weighted imaging will show you is the oxygenated state of the vessels. So during a high oxygenated state, as you can see here, the vessels appear very dark. During low oxygenated states, as you can see here, the vessels are hard to see. So this is a very good method to look at the vasculature of the fetus, as well as if you have abnormalities within the oxygenated state of the brain or underlying of vascular abnormalities. As you can see here, if we have a congenital heart disease, where we have obstruction of the outflow, the oxygenated state would be low, and therefore we'll get a picture somewhat like this. If we hyperoxygenate the mother, we will get increased oxygen to the fetus, and we'll have these bright sort of vessels, as we can see out here. And it can be used to measure the effects of certain drugs on the of the fetus, and we can see whether it results in increase in the flow rate or increase vasculature of the fetus or not. So this is a low state vasculature, and this is a high state vasculature that can be seen on Ben Bold. Another interesting view of the susceptibility-weighted sequences is that we can see that it can be used to detect sort of fetal sort of bones, if you want. This is the vertebral column of the fetus out there, this black things here. This is the normal T2 weighted sequence, and it's very poorly defined vertebral column. But on the black bold images, you can see all these vertebral segments, and you can determine whether there are any vertebral anomalies. This here is a 3D reconstruct of this vertebral column out here that we will come on later on, how these can show you any vertebral segmentation anomalies. With the susceptibility-weighted imaging, we can also see where there's abnormalities at the skull base. So of fetuses with underlying sort of ossifying the lesions of the skull base, we can see whether there's any abnormalities within the skull base using the susceptibility-weighted imaging. Now, the diffusion-weighted imaging is some indication of the Brownian movement of water within the brain. And usually we use this for detection of infarction or ischemia. But within the fetus, it can also be used as an anatomical mark, as we can see out here. It's used specifically to look at the precentral gyrus. The precentral gyrus is important because it's where the hand-motor coordination sits. And usually it should be detected at 24 weeks, and it's complete by 28 weeks. So if we're scanning a fetus and it's absent at 25 weeks, we can say that perhaps there's some problems within the Rolandic area, and you can prognosticate a sort of a delay in the motor function if you want. These are similar to diffusion-weighted sequences, but these are called ADC maps. And if the ADC maps are low, which demonstrates out here, these are associated with certain infections like CMV, and it also gives you an indication of small for gestational age fetuses and intrauterine growth retardation. You can see that on the ADC, these should not be this dark, and it is this dark. There's either an indication of an underlying infection like CMV, or there's intrauterine growth retardation. Some more sequences that we use are called flare sequences. Flare sequences are just a T2 weighted sequences, but the CSF signal has been suppressed. So these are normal T2 weighted sequences, but you can see that the contrast resolution is poor. You can't see much out here with regard to the different areas of the brain. With these flare sequences, or where the CSF is suppressed, you can see this zone out here, and this zone is important. It's called this subplate zone. It's a zone where all the neurons are rest, if you want, because they move from the ventricles to the cortex, and they're rest in the zone. So you can see the zone much better using the FLAIR sequences as opposed to the normal T2 sequences. This is important because if you have any abnormalities in the subplate zone, if you want, you can predict that the overlying cortex will be abnormal, because the neurons have migrated from the ventricle to rest in the subplate and then onto the cortex. These FLAIR sequences are also good to detect parenchymal abnormalities. These are the normal T2. It's T2 because the CSF is white. And you might think that this ventricle is a bit odd shaped, and it should be like that, but there's an extra blob there. So the question is whether that represents a periventricular cyst, whether it's a regional infarction, infection. And with the FLAIR sequence, you can see that, in fact, this abnormal nubbin that comes from the ventricle is, in fact, the region of abnormality around the ventricle and not a normal ventricular cyst. This is a very interesting concept. With time, 3D printing has become ubiquitous, and it's used for fetal imaging as well. So it's good for surgical planning. Once fetal is born, it's good for explaining to the parents of any abnormalities within the brain, and it's good for prognostication of outcome. So the data sets are acquired as a 3D data set, and what this is a normal brain. We can see that the brain is normal. There's normal interhemispheric fissure, and the brain morphology is abnormal. This is an abnormal fetal brain with an absent corpus callosum with this intrahemispheric cyst, and this is what it looks like on 3D printing. So this 3D printed image can be taken to theater post-birth, and it can be used to explain to the parents exactly what the issues are and how it can be repaired or not post-operatively. This is just an example of a 3D printed of the ventricles, and you can see that the ventricles of the fetus is abnormally shaped. And again, this can be used in the post-birth states for pre-surgical planning of how to deal with the big ventricles. So that is just on the fetal imaging techniques, and now we'll go on to fetal urology. It will be divided into 5 sections. We'll look at the morphology of the brain, how the brain is connected, how the brain functions, and just metabolic aspects of the brain. How can this be detected on imaging? With regard to morphology, why is it important to see fetal morphology? It's important because in that way we can look at normal fetal growth, and we can develop charts and atlases of normal fetal growth and development. And then if something's abnormal, we can superimpose these on the normal charts, and we can see where the abnormalities are. So just looking at the morphology, so what it does is the brain consists of different lobes. So with morphology, you can automatically segment out the different regions of the brain. Like this is the anterior of the brain, this is the posterior of the brain, these are the ventricles. So these areas here are the occipital regions, the frontal regions, the temporal and parietal regions. But within each region, it can be segmented out. And the reason that's important is that in some way we can define whether these regions are growing normally or abnormally. And it can be used as an atlas for looking at abnormal fetal growth. These regions, however, although they are compartmentalized into different subsections, they are all connected by these nodes. It's called the interconnected neural nodes, and this can be extracted from these apps if you want. So as I say, these are quantitative maps of the brain. You can detect brain volumes, normal, abnormal. You can create atlases from it. And these are usually an automatic segmentation technique. So once the images are acquired, it can be put into an automatic segmentation technique, and you get these apps coming out. Now, why is that important, you might ask? Well, it is important so you can look at normal fetal brain growth versus abnormal fetal brain growth. So here we have a normal fetus. This is the brain. A segmented volume of the fetus was made. This is the cerebellum. This is the supratentorial compartment. These are the ventricles, cerebellum, superior compartment, and ventricles. So with these methods of compartmentalization and packing, if you want, you can compare this cerebellar brain growth to the supratentorial compartment. You can compare the ventricular growth to the whole brain. As well, you can compare the right hemisphere from the left hemisphere. And in this way, you can get some normal sort of brain growth, and you can superimpose this upon abnormal brain growth. And then again, you might ask, but why is this important? It is important because you can identify abnormal brain growth, and you can identify brain growth in males and females. This is a fetal brain, and it had shown that in males they have larger areas of like septal region and frontal volumes, as well as the brains of males and females are different during the interuterine life. We were talking earlier about why compartmentalization is important. We talked about the cortical plate and the subplate. The subplate is very important since it determines whether neurons rest before they go into the cortical zones. And if the volumes of the subplate out here is small, which means the volumes of the cortex will be small. So we can compare the subplate volume, and we can predict what the cortical volume will be. So as we move on, you might say again, but why is it important to have a fetal volumetric data analysis? It's shown that in patients with cardiac disease, when you have a congenital cardiac disease, the brain volume in general is smaller. And in patients with underlying Down syndrome, this cerebellar volumes are smaller. This is especially true during preterm, the second trimester, as well as in preterm in infants. The brain volume itself is smaller than in normal term birth infants. So you can predict brain growth and brain development in utero by looking at the brain volumes. So again, why does it matter? It matters because brain volume determines neurodevelopmental outcome. We can see that patients with underlying infection, with CV infections, will have smaller brain volumes than normal, and we can see that this affects the neurodevelopmental outcome. And again, patients with congenital heart disease will have smaller brain volumes. These fetuses' brain volumes will be smaller than normal fetal brain volumes, and they will have excess in the amount of CSF space. And in addition, they will have abnormal sort of lesions in the brains. So patients with tetralogy in general will have smaller volumes of the basal ganglia and smaller volumes of the white matter. And it seems to be correlated to the amount of oxygen that the brain gets. The less oxygen that they get, the smaller the brain volumes are. These can be seen by these charts out here. So once again, we turn to congenital heart disease because this is the new kid on the block. In that, in the past we used to concentrate a lot on preterm brain growth and development, and now there seems to be a increase in the interest in fetuses with congenital heart disease. And it shows that in utero, you can demonstrate that there is a delay in the cortical maturation, and the fetuses have a reduced brain volume as compared to normal controls. You can see both the total brain volume, the cerebellum volume, is reduced within patients with congenital heart disease. And there is a negative correlation between brain volumes and neonatal ischemic injury. So the more brain, the smaller the brain volume, the increase the likelihood of underlying neonatal brain injury. Now that we have looked at why morphology is important, why is connectivity important, you might ask, but the two goes hand in hand. Abnormal brain morphology will translate into abnormal brain connectivity, as we will see in a minute. So just showing you these pictures here, these are fetal brains going from 14 weeks post-implantation up to 32 years of age. So these are the fetal brains and these are the adult brains. And as you can see with time, the fetal brains are under-connected, if you want. And as you become older, there's increased connectivity. And this is done by a process called diffusion tensor imaging, or sort of networking, if you want. And it gives you structural connectivity of the brain, how the brain is connected on a sort of architectural level. All that this says here is that with time you get increased cortical and cortical organization and stratification. This here refers to the subplate area that we've been talked about, the cortical reorganization, and that can be seen by diffusion tensor imaging. And why is this important, you might be asking? That once all these connectivity maps are made, you can superimpose abnormal brains on these normal connectivity maps, and you can predict outcome of the patient's cognitive and motoric development based on these TTI atlases. So this is an example of what I was talking about. So if you have an abnormal brain and you superimpose that on a normal brain connectivity map, this is what we're looking at. So, the subplate I've been talking about, this is a subplate region, that is the cortical region. The subplate region is where all your neurons are rest before they go to the cortical region. The germinal eminence is where all the neurons come from. They go to the subplate and then they go to the cortical plate. So if you have an injury within this region here, for instance, this is a fetal brain, this is a T2-weighted fetal brain, and there's some injury within the subplate, if you want. You can see that this will affect the amount of neurons moving from the germinal eminence through the subplate to the cortical plate. And then you can predict, once the fetus is born, you can predict that the child will have sort of preterm injury, hypoxic ischemic in this place because of this abnormal abnormality within the subplate. And these just show that there's aberration of the tracts going from anterior to posterior, and tracts going from medial to lateral due to this injury within the subplate region. Now, diffusion tensor imaging, or tractography, if you want, can be used to look at the underlying tracts as well. So this is the fetal brain, as we can see. This is the T2-weighted imaging. This is this abnormality within the corpus callosum. Usually, I have a corpus callosum that sits here, and this is the aberrant tracts that they have developed because of the absence of the corpus callosum. And we can, as we can see, these tracts are very well, they're abnormal, and they connect to parts of the brain that should not be connected. And this is why we use tractography to prognosticate outcome of these the children by looking the way these tracts have joined up, and we superimpose these on normal tractography maps, and in that way we can see how the different parts of the brain are connected to each other, or how they should have been connected to each other, if you want. So this is more so how not intrinsic brain abnormalities affect the tracts, but how extrinsic things can affect the tracts. So if there's manganese exposure in the mother versus whether she's taking any medication or any substances that contain manganese, it will affect the connectivity within the emotional areas. These are the mesial temporal regions, the hippocampus functions. When maternal, when there's methadone ingestion by the mother, it will affect the tracts because there's measurement of the underlying sort of microstructural things. There's talk of air pollution, lead exposure, which affects the long tracts within the fetus. Functional imaging is a very interesting concept, and it's new in the development, and it has to do with brain connectivity and how different aspects of the brain are connected to each other. And once again, this is all yet to be made of a functional map. So these are functional maps that can be made to see which areas are excited or not excited during noise, which areas of the brain are excited or not excited during areas of movement. And once again, these can be superimposed on normal functional maps, and you can predict whether there will be a delay in the hearing or the motor function based on these functional maps. And these functional maps are done with a sort of an epibuild, which is a thing which is similar to the susceptibility weighted imaging, where we measure this cerebral blood flow. And once again, it just demonstrates on a very simple level that there are differences between the male and female brains just with regard to the connectivity and function. So we move on to brain metabolism. Now, there are ways in which we can measure the metabolic activity of the brain. This is done by MR spectroscopy. It's usually done as a single voxel method. This is a fetal brain. This is the top part. This is the spinal cord going down here. And if voxel is placed in the basal ganglia there, this is a fetal brain again. Voxel is placed in the basal ganglia. And it's important because within intrauterine growth retarded fetuses, because the brain is underperfused, we can see that there's an increase in this lactate peak. And this gains is a predictor. Some people have used MR spectroscopy to predict neurodevelopmental outcome in neonates, and I suspect there will be the same in fetuses. We can predict the neurodevelopmental outcome by looking at the different peaks of lactate, choline, and sodium. I mean, this the choline creatinine ratio, as we can see in diabetic mothers, when the mothers are diabetic, the choline and creatinine ratio is reducing in the fetus, and it gives some indication of altered brain metabolism, because as the brain matures, the composition of the different spectral peaks should change because of fetal brain sort of growth and development. As we go on fetal motion is a very interesting concept in that they have shown that decrease intrauterine fetal motion can predict a long-term sort of neonatal outcome, but these studies have been done in a very short period postnatally, and it's not been followed up long-term. So this group at Imperial, the group that I've worked with, they have postulated that that a reduced fetal movement in the neonatal period will predict a long-term fetal outcome in the long term. And what they have postulated is that you can predict whether there are brain injury by looking at lower fetal movement, if you want. So this is a T2-weighted sequence. This is the fetus. This is the amniotic fluid. And as you can see, with time, the amount of amniotic fluid gets less, and therefore the range of fetal movement gets less. But in fetuses with abnormal brainstem pathology, they've demonstrated that in a constant intrauterine environment where the fetal amniotic fluid is stable, reduced fetal motion of the limbs can be used to predict a sort of delayed motoric development. But as I say, this is a short-term in the prenatal period, and it's not been followed up in the long term. So that's very interesting development. Now, just looking at clinical developments for fetal imaging, the fetal brain can be, once we look at the fetal brain, we can see underlying neurogenetic, neurometabolic, or neurostructural abnormalities. So this is a X-linked subependymal nodular heterotropia, and usually with a gene defect of a filament A. And what we see as this is a T2-weighted image of the fetus. We can see that there's the abnormal posterior fossa. This is an ultrasound. You can see with ultrasound, the images are very fuzzy, but with MRI, we can see much more clear images of this posterior abnormal fetus. So what we have is what we have is these abnormal sort of areas of fetal development. I'll just skip to a few ones towards the end with regard to neural tube defects with fetal imaging. You can see that there's abnormal sort of fetal, there's abnormalities within the fetal canal at here, and this abnormalities you can see with regard to the cord coming out. And I'm afraid that that's my. I'm sorry I've to rush through, but I think I had some more images, but please be free to ask any questions if you want.
Thank you so much, Ash. That was really, really interesting. I'm always totally fascinated by everything that you can see on scans that I couldn't see until you pointed out. And I'm really sorry to pull you to time. We just got other people coming through and we need to stick to time. So if anybody has questions, does anybody have a question for Ash? I have no questions on the chat box at the moment. Perhaps you could hang around for a little while online and see if anybody comes in with a question, Ash. Okay, so in which case we will move on. And our next talk is from Dulce. And Dulce is joining us from Mexico. Dulce works in the University Autónoma in Mexico. I don't know whether I can pronounce the place that she lives without being Spanish. And she's going to speak to us about parents' perception of treatment and medical care in children with endoscopic-assisted suturectomy without a postoperative use of a helmet. We have two talks now up until lunch about craniosynostosis. So it should be really fascinating. Dulce, thank you so much for joining us. Welcome.
Hi,
and
nice
over to
you
you.
again. I'm good, thank you. So let's get started, okay? Can you hear me? Okay. Okay, we want to talk about parents' perception of treatment and medical care in children with endoscopic-assisted suturectomy without postoperative use of helmet. What is endoscopic-assisted suturectomy? Is a surgical procedure in which doctors open the scalp to expose cranial bones, then cut sutures, allow the brain to expand and push the cranial bones. One of the oldest types, the surgery of straight craniosynostosis. Currently, this surgery is only performed on very young babies. It's like 0 to 4 months old. A few sutured or thanks to increased pressure of the brain. Amor, quiero mover esto, pero no sé cómo. Ay, no sé. Bueno, the procedure to correct craniosynostosis entails to effort from both parents and children. That is why to respect. A ver, es que quiero mover esto para acá. Bueno. One second, please. Es que no lo veo. Ok, esto. ¿Cómo lo hago? ¿Para acá? Okay. Okay, yeah. The procedure to correct craniosynostosis entails too much effort for both parents and children. That is why this research is carried out, to demonstrate the perception of parents in the face to such complex treatments. The development of the child's self-perception and self-confidence is mainly inflated by parents' attitudes. Okay, the materials and methods. We have 18 cases to have been that underwent of endoscopic-assisted suturectomy treatment. We are analyzing patients with different forms of craniosynostosis who underwent endoscopic-assisted suturectomy from 2016 to 2023. We are included to this study. The families that were studied for their research spent to average for 36 to 72 hours in the hospital after surgery, age ranging from 3 months to the 6 months of age, and none of the 18 patients have the use of helmet to correct the shape of the skull after the surgery and the postoperative treatment. We use a Likert type scale to use 5 simple questions for parents to define how satisfied they are about the child's surgical procedure and progress without the use of helmet. So the first was strongly agree, agree, neutral, disagree, and strongly disagree. The 18 patients were contacted by telephone for follow-up in person. For the 18 parents, 5 decided to abandon the protocol. Of the remaining 30 patients, 12 are very satisfied with the result of the pressure without the subsequent use of helmet. One of the parents commented they will have preferred to wear the helmet to improve the aesthetic appearance of the child. Had signs it still has noticeable deformation. The first question was, how satisfied are you with the aesthetic results of the surgery without the subsequent use of helmet? 11 parents was strongly agree, 1 parent was agree, and 1 parent was neutral. How satisfied, the second question, sorry, is how satisfied are you with the information provided after surgery? And just the 8% was agree, and the other percent is strongly agree. This question is very important. How satisfied do you feel about the care provided by the nursing team? The 100% of the parents are satisfied with the nursing team through accompaniment. Parents have mentioned that the support of the nursing team is crucial for them and their children. Since is the nursing team, they find close support and resolution of doubts than with surgeons. Based on your experience, how satisfied do you feel regarding your hospital stay? That 23% was agree. Based in your experience, what you recommended the medical team to try it on you, 10 parents were strongly agree, 2 was agree, and 1 was neutral. Here we have examples. You can see we have a baby with 3 weeks postoperative with corneal suturectomy in the first picture. Then we have 3 months postoperative corneal suturectomy, and then we have 9 months postoperative suturectomy. As you can see, the aesthetics results was very well. In the functional way, we have no problem. We have another patient, 3 months postoperative in a metopic suturectomy. As you can see, as a metopic suturectomy, we have like a triangle in his front. But 9 months postoperative, you can see the triangle was disappearing. In 1 year postoperative metopic suturectomy, we can see the triangle in his front was completely disappeared. And we have another patient, 5 months postoperative suturectomy. This patient have trigonocephalium, and we can see in this case we can correct to 100% the weight of his head. We have 9 months postoperative metopic suturectomy and 18 months postoperative metopic suturectomy. All the patients, we have no use helmet. The results of the 30 cases that we are studying, 18.4.6, which is an equivalent of 11 patients, expressed that the communication before, during, and after the children's surgery was effective on the part of the nursing staff and medical personnel. The duration of the hospital stays was considered adequate by all familiars and were the part of investigation. In the conclusion, all parents are satisfied with the result of the surgery and his subsequent treatment without the use of helmet. The perception of families regarding nursing care was good, is what included that the questionnaire filled out by the parents indicate that all of them will decide to opt for the surgical procedure again. Most parents always put the functional result before the aesthetic one, and thus in this conclusion, the parents are very satisfied with the functional and aesthetic results in assisting endoscopic suturectomy without subsequent use of helmet. Unfortunately, in the public health system in Mexico, cannot pay for the use of helmet because it's very expensive. It's costs like $2,000, and we can change like every year. So this is not possible to use it. That is why that important of this investigation, of this protocol. And that was all. Thank you.
Dulce, thank you so much. That was really interesting. I have one question for you, please.
Yes.
It says assisted endoscopic. So in what way is it assisted? Are you using springs or are you just doing a suturectomy?
Just a suturectomy.
I did.
You said just a suturectomy alone, without any device. Yeah.
Yes, thank you.
Thank you.
Are there any other questions from anybody? Dulce, thank you so much.
Thank you.
Okay, so we will stop now for lunch. Thank you so much, all the presenters this morning. We've had some really fascinating talks. I have to say, from my point of view, what I miss is having people in the room so that we can generate some discussion. But next year, we will definitely all be in the room in Toronto. So see you for the afternoon later. Thank you so much. To the session. Please excuse me, my voice really is starting to sound a little bit strange now. I picked up something on the way over here. So I'm now going to introduce myself. And I'm going to talk to you about setting up a new intrathecal baclofen service in the Middle East, the highs and lows. So I'll just share my screen. Oh, let's go back to the beginning. So starting a new intrathecal baclofen service in Qatar is the third place that I've been involved with ITB. I have to say it hasn't got any easier, and it still amazes me what can go right and what can go wrong along the way. So Qatar, for those who don't know, is a small country in the middle of the Middle East, made famous recently by the World Cup, which was an amazing time. And it's a small peninsula. We are abutted to Saudi Arabia. We're next to UAE and Dubai, and Bahrain is next to us as well. So Qatar is a typical modern Middle East city. It's rich from gas and oil. Previously, it was rich with pearls. They still fish for pearls in the Arabian Gulf. And it's a fabulous place to live. So some demographics for our ITB patients. There are 2.6 million inhabitants in Qatar, of which 2.3 million are expats. And yes, that means there's only 300,000 Qataris living in Qatar. It's a very skewed male to female relationship. There's 75% of the people living in Qatar are male. And we have approximately 32,000 live births a year. There's 7 obstetric facilities across Doha, and our infant mortality and neonatal mortality is very small at 4.28. Something that's much more interesting and affects us in the ITB service is the consanguinity. It's very, very high consanguinity amongst the Arabs, and about a 10% prematurity. We have over 100 nationalities who are living in Qatar, and the country has a literacy rate of about 97%. So very literate. We've got the lowest female population by percentage, as I showed you earlier. It's 3 to 1 male to females, and almost everybody lives in one of the 4 cities in Qatar. So 99% are living in a city. Outside the city is just desert, and not very many people live in the desert. Here's a population pyramid just showing you that we have plenty of children. About 25% of the population is children. We have this huge amount in the middle who are predominantly foreign laborers building Qatar. You'll notice that there's a very, very small old age population in Qatar, and these are specifically Qataris. Once you get over the age of 65 as an expat, you can no longer work in Qatar, and if you can't work in Qatar, you can't live in Qatar. So you have to go home again. So that's why it's so skewed. Lots of different people, but predominantly we have Southeast Asians who are helping everybody build Qatar. So Indians, Bangladeshis, Nepalese, and Egyptians, with plenty of Filipinos thrown in as well. I fit in the others of 16%. So the culture in Qatar is a little bit different from maybe westernized areas. The fathers make most of the big decisions for the families, and sometimes that's actually the grandfather who makes the decisions. Disability is still something that is not easily accepted in Qatar and in Arabic countries. Disabled children are often kept at home, out of sight, with a nanny to look after them. You don't see them out and about as much. Accessibility was hugely improved as we worked towards and through the World Cup, since we had so many people coming. But the ability to get hold of equipment is still very difficult in Qatar. So some families will travel to the USA, which is a 13-hour flight, just to be able to get themselves a wheelchair more quickly. Special needs schools didn't exist 6 years ago, but now we have multiple special needs schools, and the majority of children, but not all children with disabilities, can access education now. So there are about 500,000 children in Qatar, and that's the Qataris and the expats. And as I said, consanguinity is very high. The most recent thoughts were that it's about 65% of marriages within Qatar are people married to their first cousins, so not even second cousins. And as we know, consanguinity increases the risk of autosomal recessive diseases, neurological diseases, and we see many unknown genetic conditions with neurological deficits. IVF is becoming more popular because they use IVF to test the fetus for genetic issues. So if they've highlighted something within their premarital testing, which is mandatory within the country, if they pick up something where they are both a carrier, then they will often do IVF in order to be able to look at the embryo before it's implanted to ensure that it's free of disease. So healthcare is free at the point of care for all Qataris. Medical tourism is still popular, but not as popular as it was. And for expats, their healthcare comes through insurance. The issue we have with some of the laborers is that they come on a single contract and then bring their families from Asia, because it's a better place to live and work. And then these children are uninsured. So if they need to attend a hospital, their parents have to pay. And it's quite expensive. One of our other problems is ITB is not covered with most insurance companies. So I spend a huge amount of time with social workers, filling out myriads of forms and applying to the various Qatari charities who so far have been extremely supportive in funding for treatments. And as we know, ITB treatment is extremely expensive. Now, whilst literacy is high in Qatar, health literacy is not as high. And where we have produced lots of information leaflets, and we put them in Arabic and English, we still weren't finding that we were getting our point across. And so in the last 6 to 9 months, we've also been, we've converted them all across to QR codes. So when our families come to clinic, we can give them a QR code, they can flash it with their phone, and they download the information directly to their phone, and then they can read it at their leisure. They can pass it on through social media to their friends, family, and whoever else wants to read it. And we found this is a real hit. So we've now actually done some videos on diagnoses, explaining about spasticity and dystonia and things like that. In Qatar, life is very digital. There is no postal system. And so everything comes through on your phone. If you have an appointment at a hospital, then you get an SMS telling you where to be and when to be. And that's all. So we're trying to keep up with being very digital. This is the hospital I work at, Sidra Medicine, completed as a new flagship women and children's hospital in 2018, open to inpatients in 2019. And the idea was to prevent all our children going out to the UK, to the US, and to the rest of Europe, and bring expert care to them. And it is a beautiful space. On the left here, you can see one of our healing gardens where the patients can roam, the parents can sit, and the staff can have their lunch breaks. And on the right, that's our main atrium as the patients come in. There's much marble, there's much gold, and it is very beautiful. So the need for ITB services within the movement disorder team was established. And we created a team. So the team has a neurologist, occupational therapist, a physiotherapist, rehab physician, neurosurgeons, and myself as a specialist nurse. We do have SLP available, but not as a regular part of the ITB. She is part of the movement disorders, though. And our referrals come from everybody within the specialities that I've spoken about, and also orthopedic surgeries, neurology, and our international office. We are accepting quite a few patients from Kuwait. As some of our children already have had pumps put in the US, medical tourism is still popular, and they even go to Thailand sometimes. And one of the jobs I had to do when I came into the role was to design a good referral form back in for people, because we were having people arrive back to Qatar with a pump in with absolutely no idea of what sort of pump it was, what it was running at, what it had in it. So handover seemed to be quite vague, but we've definitely locked that up now. And an interesting point, I assumed if I was working in the Middle East, I would be liaising with people in the Middle East and locally. I didn't think I'd be liaising with people across the rest of the world for pumps. So we found the right space. We brought the right staff. Some of our issue has been that the Middle East is quite a transient space. So a lot of staff only stay for 1 or 2 years and move on. Therapists come and go. We're lucky that the medical staff within our service actually are very stable and will be stable for a little bit longer. But things like company reps, in the 2 years that I've been involved with this service, I've seen 3 different company reps, and they are covering both Medtronic ITB pumps, other Medtronic stuff, and 3 or 4 other companies as well. So perhaps their knowledge base is not quite as in depth as you might find in the West. It was a new discipline for many staff, so education comes up again and again and again, especially as a lot of the nursing staff are Indian or Filipino by birth and by education. And a lot of them had never been exposed to ITB services before. So it was a new space, a new concept, and a new hospital. And we needed to do a huge amount of education. Pharmacy, pharmacists, pharmacy managers, nurses on the ward, in clinic, in OR. We just trying to get everybody to understand the patient's journey through the hospital and how they could help that along. It was about making many, many new connections and connecting some specialities for which there hadn't been connections before. One of the other major problems is you're working in a country where English is not the first language, and Arabic is definitely not my strong point. Although English is the common language in the hospital and the medical records are in English, you are often working with a translator, which slows down the amount of information that you can get across in one go, and occasionally leads to confusions. So I spent many, many hours walking to pharmacy and back again to personally collect doses to make sure that they could see the digital prescription and that it was in the right place. Interestingly, we had to design a completely new system within the electronic drug system because ITB is a high risk, an intrathecal drug, and it just didn't fit the system for the outpatients, which is where we do the refills. So we had to go right back to the drawing board. We had to include IT, Cerner, we had to include pharmacy, and we had to make a whole new pathway for that. And it takes a long time to get things into the Middle East. So when I was about to do the second refill and I ordered it and went and saw pharmacy, made sure there wasn't a problem. And one of the pharmacists noticed that it had expired on the shelf. And I said, okay, so we can get some more. And she said, it'd take 3 months. I'm like, we don't have 3 months. So we ended up actually having to go to the British Embassy in Doha, and they brought some in specially, and it still took 2 weeks. We actually had to change the alarm system on it. And another problem was the fact the OPC staff, the outpatient staff, were unable to check and sign for the drug because they've only done oral medications. So guidelines, policies, procedures, competencies all needed to be completed. They were all put in the system, and then they were all lost in the system. And then I had to do it again. We had issues with getting them through, and I had to make many presentations to senior staff, education, nursing, medical, so they could understand the concept, they could understand the journey, and they could approve it. Procurement of kit, as I said, takes a long time. On another occasion, the company hadn't managed to get hold of a refill kit, and so they had to send their rep to Dubai, and he had to drive an hour and a half out to Dubai, pick one up, bring it back, and fly it back in for me for the morning that we were going to do it. And my true rep is in Kuwait. He's a flight away. And if I need him to come to a surgery, then I need to book it in advance because he's obviously very busy around the Middle East. So now we've got 6 pumps implanted, 4 Qatari and 2 Kuwaiti. We have 3 pumps that came back in siblings from the US. I've already transitioned 2 children to adult care. We have a very small adult service here. They're not actively implanting, but they will do refills. We've done 2 children's test doses this month. We've got 2 planned pumps for next month. And next month, we're going to Kuwait on a roadshow in order to recruit some more patients. So our service is growing. Slowly, slowly, we are growing. What have I learned? Well, it's never as simple as you think it should be. It always takes longer than you think it will, a lot longer. You need to check, double check, then check again, because something can go and probably is going wrong. You need to be very organized and anticipate what might happen or not happen and plan for it. Educate as many people as possible so you're not doing it alone and staff are working together. And know everything, the ins and outs of everything, so you can repeatedly explain to everyone exactly how, where, when, and why we're doing this. And you need resilience to keep going, because very definitely the reason we do it is for the children, and watching them unfold their spasticity is always worth it. So I thank you for your attention. If anybody has any questions, please pop them on the chat and I will answer them. I don't know how to stop sharing. That's going forward. There we are. All gone. Okay, I don't see any questions. It's very strange being in a room with only a few people here. We're not very sure if anybody's actually out there listening to us. So please write some questions so that we know you're out there. And now I'm going to introduce Ashley back again. Ashley, working in Boston Children's Hospital as an advanced nurse practitioner. And this time she's going to talk to us about simple tethered cord and Chiari malformation, type 1 postoperative management and stabilization. Thank you, Ashley.
Okay, let me just share my screen. I know that I introduced myself earlier. So for those of you that were here, you know that I'm a nurse practitioner at Boston Children's Hospital in Boston, Massachusetts in the United States. I worked on this project with many other members of my team. Specifically, I worked with another nurse practitioner in my group, Jen Judge, and then three actually nurse leaders from my floor, Colleen, Lisa, and Heather. And then we also had the assistance of someone from the QI group who helped us collate the data, put it together, and look at some measures for us. Additionally, we had the support of Dr. Lissa Baird, who's one of the neurosurgical attendings of the group. So just quickly, what is tethered cord? So tethered cord syndrome is a disorder associated with the fixation of the phylum of the spinal cord, which limits its movement. This abnormal attachment is associated with increased tension of the spinal cord as a child ages. So it's as they grow. Symptoms can include neurologic, orthopedic, and urologic symptoms, as well as pain. And the only treatment for this is surgery. So you can see on the normal diagram, you can see the phylum around L1, L2, and I mean the conus, and then the phylum after is loose and floaty. And then on the other diagram, you can see that there's fat in that phylum, that shouldn't be there, and that makes it stiff. And it also pulls the end of the conus to about L3. So I talked a little bit about symptoms, but the symptoms of a tethered cord, what does it mean? What was I actually talking about? So bowel and bladder dysfunction, lower extremity weakness, back pain, leg pain, orthopedic changes to the lower extremities, and manifestations on the body that let you know that someone might have a tethered cord include, but are not limited to, sacral dimples, asymmetric gluteal cleft, or lumbar lipomas that you can visually see. Sometimes you also have markings like a birthmark or hemangioma on the skin. So what's a Chiari malformation? So type 1 Chiari malformation, and the important thing to note is that this isn't listed in level of severity. Chiari, the man with the last name Chiari, just like to name things after himself. So it's 1, 2, 3, and they're just each named after him, and it doesn't have to do with severity. But the Chiari malformation is described as the descent of the cerebellar tonsils below the foramen magnum. Treatment can include observation or surgery depending on imaging and the severity of symptoms. And you can see where the arrow is pointing that you can see the tonsils descending down past the foramen magnum. You can see the bone there and the tonsils down a little lower. So type 1 Chiari malformation symptoms, they include headache. And the Chiari malformation has a very specific headache. So it's a pain that starts in the occipital part, the very back of your head. It happens with tussive movements. Anytime you're pushing, coughing, sneezing, straining, you get a pain that comes from the back of your head to the front, shoots forward, lasts for a few seconds, and then goes away. You could have swallowing issues. You could have numbness and weakness of your upper extremities, or you can have nausea and vomiting. And some children have persistent headaches that aren't this one, but a lot of the time we can't directly attribute that to the Chiari. We're not really sure if that's where it's coming from. So the problem for us as a group was that simple tethered cord release and Chiari decompression surgeries are very common procedures performed by our team. We have a large team of neurosurgeons and many of them perform these operations. We could have anywhere from 1 to like 5 or 6 a week of just these diagnoses. So they're all admitted to 9 Northwest, which is our inpatient neurosciences unit. None of them go to the ICU after these operations. And like I said, there are several surgeons who perform these operations, and there was a great variation in postoperative management by each surgeon. We also are a teaching hospital. So we have residents that rotate through. Sometimes they spend a month, sometimes they spend 3 months, sometimes they're there for a year. But trying to teach residents about what we do and what our postoperative care looks like is really difficult if nobody's doing it the same. The other thing is post-pandemic, we've had a lot of change in staff. We've lost a lot of nurses. We have travelers. We have people that are floating to our floor, and we have the same problem. How do we make sure people know how to take care of these patients if we ourselves do not have consistency and continuity in what we're doing? So the lack of standardization created confusion and delays in important management decisions. And as a result, it often led to an increased length of stay, which as a hospital that's inundated with patients and we're trying to find room for kids, length of stay, if kids are staying much longer than they need to, that's a bed that could have gone to someone else. So this is important for us. So what variations in management am I talking about? So in tethered cords, certainly pain medication selection was very varied. Bladder management, how you managed a patient postoperatively, very varied. The guidelines for activity. So we keep children flat after surgery, and each doctor was keeping them flat for a different amount of time. So there was no consistency on position or activity restrictions. And then the need for desired consultations. And in tethered cord, what I'm really talking about is physical therapy consultation. And Chiari malformations, it's the same sort of thing. The pain medication selection was really varied. The use of steroids and how we want someone to do a steroid taper, that was very varied. In both cases, length of stay was tremendously different depending on the surgeon. The need for physical therapy, and then the same thing, desired consultations. So the solution was the development of clinical practice guidelines that are meant to serve as a framework for supporting best care and to optimize patient care. They were created by reviewing evidence-based practice and then using this information to create best practice guidelines. So we did a review of the literature, we looked at what we did, and we came up with guidelines based on that. Patient care guidelines are one of the most important contributors to patient-centered care. The purpose of the guideline when we were putting it together was to streamline and standardize care for common diagnoses on our unit. We wanted to create family education sheets, patient education sheets. We wanted to create a protocol for guidelines of care. We wanted to create an order set to make it easier for residents who were rotating through to know what they needed to order. They didn't have to think about it. We wanted to optimize pain management for this population, particularly for the Chiari malformation group, who can have a lot of pain and nausea postoperatively. And we didn't want to over-medicate the tethered cords, who a lot of them don't really need kind of what we're throwing at them. We wanted to eliminate unnecessary consults. If we don't need a urology consult after, if we already know what our plan is, we can eliminate things that add to length of stay for these patients. And we wanted to decrease length of stay. We noted that a lot of patients were staying much longer than they needed to. And we wanted to create tools to guide patients toward a safe and timely discharge. So methods. So we did a review of literature and existing protocols. we gave out a survey to the neurosurgeons of common practices. We listed, like we would say, Valium, recommendations for Valium. How long do you want to keep kids flat? How long do you think they should be admitted? Do you want a Foley catheter in them after the procedure? Do you want steroids? And if so, how long do you want the taper to be? All of these things we sent out to the surgeons. And then we created a work group. And with the work group, we had the nurse practitioners, we had nurse representation, and we had Dr. Dulce Baird, who was one of our neurosurgeons. And we looked at that survey that we sent out, and we came back to the neurosurgeons and we said, listen, some of you are on this end, some of you are on that end. Can we just meet in the middle? You're all kind of close. Can we meet in the middle on this? And then we also, from all of this, created our guidelines, our goals, our order sets, and our family education sheets. And then we said, this is our rollout day. We're going to roll this out on this day. And we set an education day for the nurses on the unit, including nurse leadership. So that way, if people were rotating through, we had representation from the nurse educators, and we taught them what our postoperative, we taught them what the diagnosis was. Again, we started from scratch, and then we talked about postoperative care. We did, and then we collected length of stay data pre and post implementation. So pre and post that education. So this is what the order set looks like for a tethered cord. As you can see, the resident doesn't have to think about it. They click the admission order, which says tethered cord. And the only type of tethered cord I'm talking about here is simple. We are not talking about myelomeningocele or complex tethered cord. Positioning guidelines, flat in any position until post-op day 1. Liberalize the head of bed over 3 hours starting at 6 a.m. So that was on rounds in the morning, and that was agreed upon by the neurosurgeons. And they have to be upright, sitting upright by 9 a.m. and mobilizing out of bed between 9 and 11. So now this is an actual order that the nurses see. They don't have to think about it either. And our residents don't have to guess about when does the surgeon want to liberalize this patient. It's all in the chart. It's all right there in the order set. And like I said, everybody agreed on it. So that's what we've been doing. Urinary catheter goes in after surgery. The order is already in to DC it the post-op day 1 at 6 a.m. And then we want a PVR. We want one post-void residual after the first time that they're able to urinate after we take the Foley catheter out. And then we have orders. So we can have standing or flexible orders for diazepam, which everybody agreed in the very beginning would be good. Obviously Tylenol standing. And we do, unless you have a contraindication, we do standing Toradol for all of these kids. And then bowel medications if you need it. And then consultations at the bottom. There is one for physical therapy, but we decided as part of the simple tethered cord order set that unless a child was having trouble preoperatively mobilizing, then postoperatively we would not, a physical therapy consultation was not necessary to discharge them. And this is what we post on the wall for the patient when they're admitted for this surgery. So like it's a checklist, and we write on it, my discharge day is, and we write what we hope the discharge day will be. And so lay flat, medications to help with pain and spasm, the Foley catheter, advance your diet, go over care with nurses, sign up for the patient portal so they have their information, arrange transportation, and address prescription needs if necessary. So that's really post-op day 0. And then day 2 would be post-op day 1. And so they can see right there clearly lined out what the expectation is for the next day. So they know. And then on there, it actually says they don't need to be cleared by physical therapy, and they don't need to poop before they go home. And they know that. And this is the education sheet that we created to go with it. So we hand this out. The goal would be to hand this out pre-op. We haven't been as successful in doing that as I wish we were, but we have been handing it out like first day so they can see some of this stuff. And then this is the Chiari decompression order set. It's essentially the same. And we do want physical therapy on these kids, but we want them to basically do neck range of motion so that they're not as tight. And that we think will decrease length of stay if they're already moving their neck a little bit from the beginning. But there's the order set for tapers that we agreed upon too. Dex tapers, steroid tapers. And then this is the one for the Chiari surgery, same thing. And we anticipate that Chiaris will stay a little bit longer. And what we think is they'll probably stay 2 to 3 days until post-op day 2 or 3. And this is the education sheet for them. And so we haven't, I'll get to this probably, I think it's in one of the other slides, but we haven't yet analyzed the data for the Chiari malformation, but we've looked at the tethered cord. And the guidelines for management has definitely, it's a notable decrease in length of stay. So the order set and the SMART text have definitely aided in it. The nurses see the orders right away post-operatively, and they know that before we've even said it, those kids are already liberalizing on post-op day 1, and the Foley catheter is already out. So we don't even have to say it. It's great. And you can clearly see education day and then post-intervention data, the length of stay is way decreased. It was actually a meaningful difference, a statistically significant difference. So we haven't yet implemented the next steps for the Chiari decompression. We've created all the tools. We've got everything ready. The order set's ready. It's being used a little bit, but we haven't done the nurse rollout yet. So the next steps would be, I think it would be good for us to look at patient and family satisfaction with their inpatient stay to see if they felt rushed or see how they felt. I'd really be curious to know if being like this informed, having that thing on the wall it would be very helpful for me. I mean, but I'm very like type A. I think it would be very helpful for me as a patient to be able to see that and to know what my stay was going to look like. But we have to investigate that a little bit further. We also want to look at if we've decreased return to the emergency room or if we've increased it by having a shorter length of stay. And then eventually this really should be submitted to a major journal so that we can submit our guidelines, our tools, and our outcome data to show that it really was helpful for these families and these patients. And and for the nurses, I think this has really helped the nurses. I think knowing what your patient's admission should look like this in a stepwise fashion, especially if you're a travel nurse or a float, which the United States, we have a lot of travel nursing right now. So that's not your primary. Neuroscience nursing might not be your primary thing that you do. So it's got to alleviate some stress, but we have to look into that and actually investigate it. And so those are the big things. And that's where we're at now. And these are my references. And if you have any questions, go ahead and put them in the chat, and I'm going to hand it back over to Jenny.
Ashley, thank you so much. That's really fascinating, and reminds all of us that having guidelines for everybody, doctors, nurses, and parents, always leads to a faster exit. So we are now going to go to our last invited speaker, Dr. Alfred C., who also works at Boston. And he is going to talk to us a little bit about advances in endovascular approaches to hemorrhagic and ischemic stroke in children. I think he's had a very interesting training program where he's done both open and endovascular stuff. So he comes from both camps, and I think uses both sides to treat his children. So Alfred, I'm going to leave it over to you. Thank you so much for coming today.
Thank you so much for having me. I am hiding in the side so that my camera will focus on some of the background for everybody else to know what it's like here in Viña del Mar in Chile, since both Ashley and Jenny are kind of in the dark holds of the conference center. Let's see. Can you stop sharing screen, please, Ashley? Thank you. So I know I'm late in the day. It may be various times of day for everybody else. So, but nevertheless, people have been on conference on a Zoom for many hours. So my goal here is to show you a number of cases to motivate some of the innovation and some of the perspectives. Sorry, give me 1 second. Still. All right, let me confirm that it looks good. All right. So my goal is to supplement the talk that you heard earlier, which was discussing some open surgical approaches to pediatric stroke, both hemorrhagic and ischemic. And so I also do endovascular. And certainly I know that some centers, this is the realm not managed by neurosurgeons and is kind of handed over to the interventional neuroradiologists and sometimes interventional neurologists. But I certainly want to motivate you all to take that back over and kind of bring that into the realm of neuroscience and neurosurgery again, so that those patients are getting comprehensive care from all perspectives. So let's see here. I don't have any specific disclosures, but in case anybody falls asleep, we'll go ahead and start off by just telling you the takeaway points. That way you can take a nap and pop back down the Zoom whenever it suits you. We'll tell you 2 ischemic cases, 2 hemorrhagic cases, and these are really all the takeaway points that I would say are the most critical. So this slide, you'll see it again later on. If you take away nothing else, just remember that, a lot of the hemorrhagic stroke in children is driven by arteriovenous malformations, and arteriovenous malformations present with bleed in children more so than they do in adults. So 2/3 of AVMs that we see in children are coming in with bleeds. They bleed with smaller lesions than adults do. There's more posterior fossa lesions than there are in adults. And ultimately also having an exclusive deep venous drainage those are 3 factors that actually lead to higher risk of bleeding. Probably the main way that we can go wrong with treating AVMs in children is missing the recurrence and the residual. And oftentimes this is even when the pictures look great for a 6-month and a 1-year period, you can certainly have a residual and a recurrence down the road. So long-term follow-up is absolutely critical. I'll show us some opportunities where it looks like there may be some change. The ischemic stroke, the key takeaway points are endovascularly, we can do a lot for large vessel occlusion, acute ischemic stroke that wasn't really available about 7-8 years ago. So don't be afraid. Advocate for the kids to get imaging expeditiously. TPA and TNK, or tissue plasminogen activator and tenecteplase, are not really the only options, nor are they likely the most effective options. And certainly in children, neither of them have been well enough studied. Granted, mechanical thrombectomy is also not well enough studied, but the number needed to treat in adults is just so remarkably low that it's really hard to imagine that it's not valid in children as well. So thrombectomy is effective and potentially even more effective in children than it is in adults. A young kind of age boundary that we're seeing in practice is probably somewhere around 18 months. But I don't think it's that we cannot do it for younger children. It's just that we don't see the problem in the same way, or we don't identify it until later on in the disease process. And then where can we go wrong? The thing to remember is that in children, large vessel occlusion, ischemic stroke, a blockage of a main vessel is so much more rare. So it's a lot easier to find other causes of these unusual symptoms that are stroke mimics in kids. 90% of them are not a stroke, whereas only 3 to 5% of the adults that are coming in, 60-year-olds with a facial droop or an arm weakness, those are basically all strokes. So it's a lot more tricky to come up with a workflow at pediatric centers, pediatric hospitals, to be able to identify these kids and take care of them quickly. And we'll talk about advances there as well. So first, let's try to drive this and motivate this based on some cases. This is a 10-year-old player. They were playing a 10-year-old child. They were playing American football, the one where you touch everything with your hands instead of with your feet. And they were hit in the head because American football, like most things in America, is just arbitrarily dangerous. So we see here, there on the left-hand side, this is a non-contrast CT head axial cut, and there's this subtle asymmetry at the back of the head. So on the patient left, there's a slight density here. The rest of the scan is unremarkable, except for that one position. So the outside hospital astutely said, the child suffered head injury. Let's send them over to the main pediatric center. And we got this MRI, which shows in that same location, not a new bleed, not a traumatic subarachnoid hemorrhage or a traumatic intraparenchymal hemorrhage, but rather a little tangle of vessels. So ultimately, this diagnosis is different. He actually didn't have a bleed. He just has a little bit of calcification, and he has a new diagnosis of a left occipital arteriovenous malformation. This is then a catheter angiogram. And so we can rotate the image around so that we can understand the structure. And what you'll notice here is that hey, Alfred, the picture only shows the left side blood vessels, right? So that's the unique thing about catheter angiography is it is by nature selective and targeted to a specific question. So some of the nuances that you may want to think about when you're ordering different kinds of scans are what is the advantage of one modality versus another? And certainly catheter angiography is very much a question-based, hypothesis-driven kind of study. So it's always going to be thinking about what the pathology really is. To some extent, things like CTs and MRs are a little bit less hypothesis-driven. You can send someone into a CT or an MR, and really you don't have that many options to tweak on a CT. And on an MR, there's kind of a basic set of sequences. So if someone has a symptom, you just send them in. With catheter angiography, not only do you have to know which vessels to look at, but you really have to think about what you're looking for. Are you looking for an abnormal structure, or are you looking for abnormal physiology? So the body's blood flow and flow patterns, right? This three-dimensional rotation gives us a really good sense of the structure, but it actually does us a little bit of a disservice about the physiology, because this is a movie in space, but very much less a movie about time. And any one of us watching any movie, we wouldn't be interested if it was just kind of a picture or a moving picture looking around the certain environments without the narrative developing, right? The story or the plot line. So then important piece comes here when we look at biplane cerebral angiography. Even though we can't see the 3 dimensions as obviously, you see here the key takeaway and the key nuance of catheter angiography is that it's an evolution over time. So placing a contrast in a vessel and then watching where it flows and is it appearing in the structures that it should appear in at the correct time during the imaging. And so here we have this arterial structure coming in here, and then there's this high density of arterial or really nidal structure that's a tangle, and then uniquely, we also see these venous structures. And the key distinction here is that these venous structures are captured on the same image plane or the same image time point as the arterial structure. So this is what we define as arteriovenous shunting. And that's an important part of this pathology, right? If you don't see arteriovenous shunting, you might not call this an AVM. This could just be some sort of hemangioma or other hypervascular structure. For example, sometimes tumors can have a lot of blood vessels in them, but you see the arteriovenous shunting here, and that's an important distinction. And you really don't see that on CTs, CTAs, or MRs or MRAs. So that's an important way in which angiography is complementary, right? So what we have here on the left side picture is what we call a lateral projection. So it's going from the left side of the head towards the right side of the head. If I had the unsubtracted picture where I don't have the computer hide all the parts that aren't moving and aren't changing with time, then you would see that one of the ears is right here in this region right in the middle of the screen, and the other ear is perfectly overlapped with that. So there's a left to right picture, lateral projection of the left internal carotid artery. On the other side here, sorry, my Zoom stuff is, on the other side here, this is also a lateral projection, but this is a different artery that we're injecting the contrast in now. And you see the shape of the vessels are different. And so it's important for us to be looking at that, to know, A, what we're looking at. And also we need to look at these vessels each individually. And you'll notice that the pattern of filling is different on one than the other. The same lesion with 2 different vessel injections on a catheter angiogram, you will actually see a different structure. So again, this is how the hypothesis-driven nature of angiography is unique and an important complement to what we see on CTs and MRs. And here we see that if we only thought about what the left internal carotid artery flow supplies to the AVM, we would actually miss some components of this malformation. So it's important to think about that and ask that question whenever you're sending a patient for these tests and also checking on them afterwards. So what do we do for a patient with this kind of problem? So there's broader approaches. You actually saw all of this morning, so I'm going to be able to skip it a little bit, but medical optimization, microsurgical resection, endovascular embolization and nuances of that, radiation therapy and nuances of that. And like you said this morning, combination therapy is really critical. All of this is compared against the natural history, right? The broad approaches, each one of them has advantages and disadvantages. So no center should really be uniformly performing one modality without consideration for the rest. And really the centers that achieve the best outcomes are tailoring it to each individual patient's pathology, pathophysiology, and the patient and their parents and their family's risk tolerance. A lot of these treatments, some of them are a specific procedure. And intuitively, we know, all coming from the surgical field, we know that procedures have a very high upfront risk compared to things like medical therapies, or in reality compared to radiosurgery, where the effect of that therapy is taking time, often months to years to accrue. And so that same kind of slow, gradual accrual of effect means the risks also come in a slow, gradual fashion, oftentimes not until 6 to 9 or a year or two later, 6 to 9 months or a year or two later. We do know that these risks and benefits of these approaches are probably slightly different in kids than they are in adults. People certainly are at a higher rate of recurrence when they're younger. So that changes some of the risks and benefits that come with some of these procedures. I think the major impact is actually it changes the natural history risk, because someone who's living 4, 5, 6 decades is going to continue to be at risk of bleeding from the malformation if you don't treat it with one of the other modalities. We also remember discussing before that there are smaller AVMs, and we'll discuss this again later with some of the data. Ultimately, though, again, none of these are single modality agent that's a go-to fix for every single case. And ultimately here, it's important to remember this is a team approach. And the more people on your team, really, the better outcomes you're finding. This is a team approach because I learned from my predecessors, and they had built a team that I can leverage when I'm seeing these kinds of problems. So people that you all may have encountered or heard from, Dr. R. Michael Scott, who's a well-known pediatric neurosurgeon, Edward Smith, who's my direct mentor, and Darren B. Orbach, who's my direct mentor on the endovascular side. But this team is not just the proceduralist, not just the surgeon or the interventionist, really is a number of different specialists, right? So I have here listed, everybody intuitively says, yeah, there's the interventional person, there's a neurosurgeon. Maybe some people remember that there's a stroke neurologist and a radiation therapist, but there's other people in this team that all play a crucial role. So each one of them can contribute to the ultimate outcome as much as, or even more than, the proceduralists themselves. So the neuroanesthesiologist, having a specialty team to be able to manage these complex cases during any kind of procedure is absolutely critical. The nurse practitioners who facilitate the patients in their preoperative, postoperative environments and help guide families during the recovery process, really inform the families. And I think you all saw just about 15 minutes ago how critical it is that you can have standardized care. And the standardized care doesn't just kind of impact, for example, the medical staff or the surgical staff kind of guidance, but ultimately having everybody on the same page means that everything can be executed more efficiently. So cutting down, in that case, a 2-day hospital stay to 1 day, that's really a 50% reduction of the hospital stay. And if you had 50% more beds in your hospital any given day, there's no hospital in the world who would not implement a worksheet program and a patient education program to achieve that over just the span of a week or two of starting in such a program and achieving that kind of impact. And again, that's as impactful or more impactful than even doing the procedure itself, right? And then ultimately also having the neuroradiologist inform your management, guide you, and give you all the data. This is not just us in Boston, but this is other centers as well who have shown that multimodality conferences, multimodality treatment is absolutely critical to achieving the best outcome for patients in the short and the long term. If we go back to that case now, don't be confused here. These are magnified pictures, and some of these are from a slightly funny angle. So these are no longer just straight left to right pictures. But what we see here, we've now taken a number of catheters. And so these are little tubes. The first one's probably the size of, a power cord for your hair dryer. And then the next one smaller is about the size of a power cord for one of your cell phones. But you see the tip of one of the tubes here. And inside of that, you see the smaller tube going inside these vessels that are increasingly small in caliber, and taking all the loops of that until finally it reaches where the arteriovenous malformation nidus is. And injecting contrast there can tell us, is this little catheter now at the location that's right up against the nidus? So if we try to block off this blood vessel with either coils or glue, various things that fill the vessel and block the blood flow, is that going to just block the malformation? Or will it also, unfortunately, block normal blood flow to the regions of the brain right around this? In this case, we see that it only fills the malformation. We see the tangle of vessels and the outflow. So we know that we're relatively safe. This is a second view of that same catheterization. And you can see how the two views are important to combine so that you understand it. And you don't necessarily see the structure in the same way on the two different views. Here, this is after we've done the procedure. We've placed little bits of glue, and you can see it's not a perfectly molded shape to the vessel. There's some glue that actually follows the catheter back, which is one of the pitfalls of endovascular therapy. You cannot manage it in the same way as surgical therapy, where you can put a precise clip or a precise cut or an instrument on the individual millimeter that you care about, right? So everything has some backwards flow and forwards flow because it's all liquid products and kind of glue type products. And here we see, though, that most of this is now blocking a large portion of the nidus, and on the anterior to posterior view, as well as the lateral view that I've then magnified here for you to be able to see in the middle of this. We see this picture showing that after that embolization, the vertebral artery, this is a face-on view now, so left side of the head's here, right side of the head's here. We're going to see the malformation here. You see a little faint speckling in this region. That's your nidus with the glue inside it. Sorry, this isn't. So that's your glue. And then next to it, you see there's still a little bit of arteriovenous malformation left over, right? So you see right there, but now it fills much slower. The arteries have already filled and are now going into the smaller capillaries and even almost to the veins. And then that's when we see the nidus, but we don't see the veins appearing as obviously anymore. So that way we know we're starting to have an impact on this malformation. This is that side view that we recognized from earlier on. And here it's actually pretty faint, right? So there's a little bit of the AVM nidus right here, and the venous drainage appears slightly early, but it's not nearly as obvious as it was before. I know we're always going to run short on time, so I'm going to skip forward. We have a couple more pictures of approaching that residual amount of nidus. And then just another nuance of the technique, how do we achieve some of these catheterizations? What you see here is a highly magnified view of our work, our navigation. And so you see the white shadow of the vessels. And so those are shadows that the computer projects onto the picture. That's based on a prior image where we fill the vessel. Sorry about this squeaky door in the background. Those are the vessels that are shown on the computer based on what we injected, 2 minutes, 5 minutes ago. And then we use that as a roadmap, a guidance of where our vessels are supposed to be. And now you see this little black wire that we're navigating and trying to advance around some of these vessel structures. Unfortunately here, this wire, despite being, this one was 0.10, 0.010, so 10/1000ths of an inch in diameter. Despite being that small, it was unable to make some of the turns on this vessel, so we were not able to get right up against the nidus in this situation until we switched out for some additional devices. Again, I'm going to skip forward a couple of pictures. This is a little bit more glue that we put in now, before and after. So we showed that there was still a little bit of nidus left when we had this much glue in, and then so we filled up a little bit more of that AVM itself. After embolization, you can always cause new problems. They can be similar to the problems that can be caused by surgery. So in that region, we can cause new vision problems. They could be temporary or permanent. You can cause a bleed if you injure the vessel with the wires or the catheter, or you can cause a bleed by blocking the outflow, the way the blood gets out of the AVM, without adequately blocking the inflow. You can imagine that just being like a really bad traffic jam. We got this picture overnight just to make sure that there wasn't a new bleed, new problem, because this child did have some fuzziness of the vision on the right-hand side. Not so much so that I was concerned that they had a stroke or a definitive bleed, but just enough where I wanted to know before they went to surgery how much irritation there was. And now you see there's a little bit of white signal on this MRI right around where that AVM used to be. So there's a little bit of edema. So in this case, we started them on a little bit of steroid, dexamethasone, to help with that edema and reduce those symptoms. But ultimately, they got better over a couple of days after surgery. So we know it was not a permanent injury. Anytime we do AVM surgery, whether or not we embolize it or glue it off, we do check during the surgery before we wake the patient up, is there any residual arteriovenous malformation? This picture is a face-on view and anterior-posterior AP projection of the left internal carotid artery. And we see here, fills all the normal brain tissue. There's no longer that malformation that used to be right in this location right here. Same thing when we inject the vertebral artery. Remember, we talked about how each vessel shows you a different part of the AVM. So it would be negligent if we only looked at the internal carotid artery in this case, because we knew before that the vertebral artery could also supply AVM. And here, again, we don't see any AVM. And just as we discussed, a principle of angiography is we're looking at it as a movie, not just as a static picture. So we don't see early venous drainage. So that's another key sign that there's no AVM left here. So what do we do for children after surgery? We just do an angiogram, wake them up, send them home. So even after that recurrence, or after that treatment and the intraoperative angiogram, we're checking for recurrence. So our standard in Boston is to do a 6-month MRI, MRA, a 12-month catheter angiogram, typically also combined with another MRI, MRA, and then annual MRI, MRA for at least 5 years before we then space them maybe every other year. That being said, we're generally following these into young adulthood, oftentimes into the early to mid-20s, because we know that the biology of brain AVMs is a little different in children than it is in adults, and there's a higher rate of recurrence, even after complete cure. There's brain growth, vessel growth, even throughout the teenage years, so we certainly have seen late recurrences at 5 years or later out after treatment. What are some of the particular considerations in children? These are some of the takeaway points that we discussed earlier. So I'm sorry, these are a little bit smaller slides. So rupture presentation, about almost 2/3 of kids are presenting with ruptured AVMs, not just with incidental diagnosis, although there's still that third that are. These kids, all of them now in this column on the left-hand side, 90% of them are having AVMs that are smaller than 3 centimeters. So these are small AVMs compared to adults where the size is a little bit more variable. Only 15% of these are larger than 3 centimeters. Okay. The bleeding risk is probably a little bit higher. We saw that they are more likely to present with a hemorrhage than adults are, but there are some key factors which also lead you to maybe worry about one child more than another, even if they come in without a hemorrhage. So that 1/3 of kids who come in with a unruptured AVM, which ones are more likely to bleed? They're the ones, again, that are smaller. There's actually a 2 to 3-fold increase in risk of bleed when they are smaller than 3 centimeters. Okay, so a smaller AVM, more likely to bleed than a larger AVM. Deep venous drainage, probably about 3 times the likelihood of bleeding if it's exclusive deep venous drainage. And this is stuff that is not shown by just one center and one set of patients, but similar patterns. In this case, this other center says, half the likelihood if it's a larger AVM. So you see that the larger AVMs, there's a decreasing odd. So don't be confused by the 0.5 compared to the 2.8 up here. But similar, this one's 4 to 5 times the odds ratio for exclusively deep draining AVMs. Our group was finding about threefold. So these are the same order of magnitude. And some other groups have also found those posterior fossa, the cerebellar AVMs, can have a higher rate of emerging. So those are the ones to watch out for. What else is different about kids? We talked about how the biology of brain growth and vessel growth is different during childhood than in adults. The molecular mechanism behind these AVMs is likely also different in these kids. So, back in 2019, I think was the first report of somatic mutations. So focal regional mutations in the brain vascular tissue that led to the formation of brain AVMs in mostly adults. They weren't studying a lot of kids then, and they're looking at mechanisms in the KRAS and BRAF pathways. So the RASA pathways there. And people have then been able to study the same phenomenon in children, but it's interesting that the distribution of mutations is actually a little different. So this isn't surprising. We know, again, that kids pediatric pathology is not always identical to adult pathology. This means that if we ever come up with molecular therapies, they will probably be a little different in kids than they are for adults. And we'll need to consider that before we generalize our treatment strategies. Key takeaway point, you remember this on that first slide. Long-term follow-up is hugely important because these kids can certainly have residual AVM, especially if they present with a bleed. That hematoma itself to block and hide a little bit of AVM that's on the side and separate that from the rest of the AVM. And people can encounter residuals in that scenario and recurrence, even when these kids look like they have no residual AVM left because of the continued evolution and growth of the vessels and proliferation of the endothelial cells in children that doesn't happen as much in adults. They can have recurrences years after, so it's important to follow them. Here, we talk about our experience at Boston Children's Hospital. So rupture status is a key finding. When you operate on them is another key finding. And since 2008, we have established a standard of care that's also now, in the United States national guidelines for perioperative angiography to make sure you're not missing a little bit of residual. If they have an unruptured, scheduled elective AVM, it's very, very unlikely that they're going to have a residual. But even there, you can have a 2% risk of recurrence years down the road. Certainly the ruptured ones are much more likely to have residual or recurrence. So we're talking about 7 up to 75% sometimes if you're doing surgery and there's something funny on the angiogram, but it's not obviously an AVM, you still may need to come back. Okay, so there's much higher rates than there are in adults. Some people critique the multimodal therapy. I'm going to push past this a little bit because you already heard a little bit about this morning. We obviously recognize that the risk of bleeding continues to accrue throughout their life, and that's why we push for treatment of children even more so than we push for treatment of adults. And ultimately, the treatment profile, the safety of it, is pretty similar to that in adults. It's somewhere on the order of a few % of complications from endovascular combined with microsurgical treatment. The team experience we know matters. The more volume, the more experience at a center, the faster the recovery process is and the lower the likelihood of complications. So there are some things coming down the pipeline, more and more, especially in Europe and in South America. People are using transvenous embolization. There's a number of reports about this. These are now 5 or 6 years old, but it's not entirely clear if every center should be doing this. Certainly, we do not routinely do this in Boston, and it's certainly not most cases that are amenable to endovascular transvenous treatment. I have here a combined case. Here we have the AVM, the tangle of vessels right on the surface of the brain, and I wanted to show you what transvenous embolization can be like. In this case, we actually did it with an open surgical approach. We did a standard craniotomy that you might do for a AVM resection. We measured the flow, we isolated the veins, and then we catheterized one of the veins. So here you see one of those catheters, just like your cell phone charging cable, and then we have it plugged into a vein. We're going to release this, and then we're going to fill this with onyx. And this is what can actually be happening during a transvenous embolization when you don't have the head open, but in a case where we've opened up the head, it's actually much more controlled. We're going to fill this AVM with some onyx so that there's less blood flowing through it when we're trying to resect it. You remember this morning, that operative video touching a certain part of the AVM led it to bleed profusely and made the resection much more challenging. Filling it with onyx can make that much safer and much more manageable. So here we're altering some of the inflow, and now you're going to see a fast-forwarded version where you see this filling with this black material. That's the onyx. That's a polymer that precipitates and forms this solid cast. And then all of a sudden, you're going to see inject enough, and you see rupture of this AVM. If this was happening with the head closed without having had this open surgery, obviously that's going to result in some rapid increase in the intracranial pressure. But here, everything was controlled. We're already prepared. There's no ICP spike for this patient, and we knew that the AVM itself was filled, and we're ready to do the resection. Why is embolization itself not enough? Why do we still combine it? We see here, despite filling the entire AVM, there's all these little tiny vessels that go in and out of small channels in AVM. This is where residual malformations and recurrent malformations come from. These vessels have onyx in them. The ones right next to them up here don't. Those are the ones that gradually over time can grow and develop into a recurrence of the AVM. Jenny, do you mind just making sure I have a sense of the time? Do I have like 5 or 10 minutes left? while we see if there's kind of a specific update, just because I don't have a clock on me or watch on me. Ischemic stroke. Key takeaways, right? As young as 18 months, people are able to do thrombectomies to take out a large clot in a major vessel. Where can we go wrong? Misdiagnosing these strokes, because in children, most people are not coming in with a blockage of a major vessel. Okay. So those are the things you have to think about when you're trying to set up a stroke program at your institution. Motivating this 3-year-old boy has a cardiac history. These are obviously the patients that are super high risk. They've just had a procedure, kicking off little pieces of debris from the heart valves. And here we see on this left-hand side of the head, this child has a little bit of hyperdensity right there. That's actually the mitral valve debris stuck inside of his middle cerebral artery on that left-hand side. Doesn't exist on the other side. He's got bad blood flow to that majority of that hemisphere. And thanks, Shani. And what we see is that he came in with exactly the symptoms that you would expect. He has a prominent right-sided weakness. He was very lucky that his parents observed this. And within 45 minutes to an hour, he was brought into the hospital, and we had this image to know this is a stroke case that is very concerning. At that time, he had a National Institutes of Health stroke scale, NIHSS, of 14. So he was, a little bit drowsy. A 3-year-old, maybe not always going to follow commands if they're kind of drowsy, but he clearly had a left gaze preference. He was not looking towards the right-hand side. His right arm and his leg were very clearly weak. This kind of problem in an adult, 100%, this is a large vessel occlusion. They have a significant deficit. They have an image showing that occlusion in the CT, even though it's not showing you the vessel structure. This, in an adult, would probably go directly to an angiography suite for a thrombectomy at most centers nowadays. That being said, he was early enough that he got TPA, and then he improved. This is what we hope TPA and TNK can do, right? So his stroke scale decreased, so his deficits reduced. It went from 14 down to 7. So now the question becomes, did he reopen that vessel? And if he did, is there really any benefit to taking a 3-year-old child to an angiography suite? Is the residual deficit just a permanent injury because now he's suffered the stroke and that part's not coming back? So we needed to do further imaging, even though he just had that CT. Sorry, this CTA is actually while he's getting the TPA. So we see this cutoff here. So on the left-hand side, we see that the middle cerebral artery continues past. On the patient left-hand side, you'll see there, it just stops, right? It never continues. Same thing, now we have the vessels filled. We see that left-hand side of the brain does not have the middle cerebral artery, but the right-hand side does. With that improvement, what we needed to do was get an MRI because I couldn't tell how much of his problem was related to a permanent injury that I was not going to be able to fix, and how much of it was because there's still not great blood flow. Diffusion-weighted imaging is one of the ways that we tell the permanent injury status. This is bright on diffusion-weighted imaging, dark on adjusted diffusion coefficient. This is the extent of his permanent injury. So, this can explain a little bit of his weakness, but it's very unlikely that he would still be neglectful and not particularly alert, because those are all cortical signs. So this is the region of the brain that is still at risk. And you can say, well, how can we be sure of that? Now we have the perfusion images. These are tiny pictures, they're thumbnails now, because this is how our hospital shows it. We see that dark region on that side of the brain on the surface. All of this area right here that does not have the permanent infarct still has that perfusion deficit there. So all of that area of the brain is not getting great blood flow. You can see here this darkness on the susceptibility weighted image where there's poor blood flow, in contrast with the other side where those dark lines are not quite as prominent. So he needed a revascularization. This is a picture that's somewhat familiar to you all, a front to back EP projection of the left internal carotid artery. We see here as we follow this branch up, it divides into the middle cerebral artery coming this way and the anterior cerebral artery coming this way. And here's that cutoff. We saw this on the CTA, right? When we watch how this flows, you all remember this is all about a movie, an action movie with a plot, not just a static picture. And we see as we follow that plot line out, this area of the brain does not fill in the same way that the rest of the brain does. That's the deficit. That's where his problem lies. So here as we watch this on the side view of the same vessel, same injection, we notice there's that area that's outlined in the blue where there's poor blood flow. He's a child, so he has, you know, a lot of attempts at revascularizing, and his own body is trying to work it out and find an alternative solution. And we see some of these blood vessels try to come backwards from the outer surface to try to come into this area because it's not coming from the inner surface from inside to out. So what do we do instead? We take a little tube and then we bring it all the way up to that blocked surface. So right there, we pull that clot out, and now we see this vessel fills in the forward direction. And that area with the blue dashed line now is filling again with blood flow and contrast, in contrast to before, or in a difference from before where it didn't have that contrast. This is the prior, and this is the current. So this is a successful revascularization. This is a side view of that same vessel. And now you see those vessels come in from the bottom up towards the top of the screen, right? Now these vessels are filling upwards rather than stuff trying to come backwards. So that's mechanical thrombectomy. He got more MRIs, and we show that he already had this permanent injury, but the rest of that brain was salvaged, right? That didn't suffer more stroke, even though it wasn't getting enough blood flow. Ultimately, he left the hospital after 3 days and recovered almost all of his function with physical therapy and with some time. We'll skip past that. Key takeaways, right? In children as young as 1.5 years old, we definitely have seen and have been able to technically revascularize, reopen those blood vessels. The likelihood of good outcome, modified Rankin scale of less than 2 at about 3 months, is somewhere around 90%. This is even better than what we see in adults, okay? So we are able to do thrombectomy in children as young as 1.5 years, and the impact of it is as good as anything that we see in adults. The mortality and complications of thrombectomy are 1% to 2%. This is also as good as or better than what we see in adults. And this is the adult randomized controlled trials with hundreds of patients each from 2016. Again, we're achieving as good or better, right? The key differences are in the kids, most of these are heart-related problems. These are kids with heart disease oftentimes. These are also kids who have blockage of vessels that are not just the middle cerebral artery, that front vessel, but also the posterior circulation. So oftentimes the basilar artery. And because of that, it's harder to diagnose them. They might not just have weakness of one side of the body. It might be an alertness or a drowsiness problem. So this makes even that stroke mimic and workup problem even more challenging, right? Imagine a 3-year-old coming in, their parents say they've been kind of drowsy all day today. How do we know this is a problem that's a stroke versus hypoglycemia versus a flu? It's very, very challenging. And this is the kind of problem that you all are dealing with. And we don't have a perfect solution, but I think having a high index of suspicion is always important. This leads to late diagnosis. They're no longer a candidate for TPA or tenecteplase. And so this is why advanced imaging is important to find out, hey, is there still brain to salvage? And should we be taking these kids to thrombectomy? I typically do about 4 a year now, which is very, very uncommon, right? I do about 3 of these thrombectomies when I cover the adult hospital once a month on a weekend, whereas in the pediatric hospital, I'm only doing about 4 a year. A lot of people have reported on this. Probably Bhatia 2019 is the most comprehensive, where they actually collected all other people's experience as well. Again, they're showing patients just under 2 years old, people are still doing that. And we can perform this certainly as young as 6 months to a year of age even. And we're using similar devices, 4 French, 5 French, 6 French sheaths compared to adults. We're using centrivers the way we're using them in adults. We're using aspiration catheters the way they're using them in adults. So have courage and advocate for your patients to get the thrombectomy when it's indicated. Another case, this one, I think I'm running pretty short on time, so I'm gonna jump straight through this. Multiple presentations with these funny little dots, okay? Comes back to another hospital multiple times, and then finally they send him to us and we show his basilar artery is blocked up here. Took about a month of repeated episodes to really finally have a severe enough episode that this is what's visible. And then I took him to a thrombectomy. We note here that this vessel is where the left vertebral artery got contrast filling in it. and it fills backwards into the right vertebral artery just because there's nowhere for it to go. That basilar artery is blocked. But there's a little bit of irregularity in this vessel. It's not nice, smooth black lines. There's a little chunkiness to it. That's actually his source of problems. And, you know, I am also human. I didn't appreciate that on that first diagnosis. And ultimately, you know, he had a recurrence of his problem. We pulled his clot out. And then now this is what the basilar artery looks like filling normally, right? We see it going upwards. All of this territory, that entire vessel was previously blocked. Now he's getting forward flow in that entire space. And as a result of that, you know, he has that's, you know, subsequent evolution of stroke, but all this area up here, all of this was, you know, salvaged and preserved. And so he was able to recover, go back to running cross country, 5-kilometer runs at a time for a middle school child. He did a fundraising race to kind of increase advocacy and awareness of pediatric stroke. He's really come back quite a bit, but he even had another stroke. So I actually had to go back in another procedure because he didn't get adequate medical therapy since we didn't realize the source of the recurrent strokes was right in this vessel right there. Ultimately, because he still had strokes despite getting anticoagulation and 2 different kinds of anticoagulation, we had to block that vessel off. And now you see here, he's fully reliant on this right side vertebral artery to do the flow. And there's no more flow coming from this side. Let's see here. So let's see the case takeaway. Key thing here, again, the pediatric strokes are often challenging. There's also a risk of recurrence of the pediatric ischemic strokes. Their underlying cause of their stroke can persist unless you treat that. That often means medical therapy. Having a very good collaboration with your stroke neurologist is absolutely critical, right? And then we've discussed this multiple times, stroke mimics. Kids are presenting with migraines, seizures, Bell's palsy, conversion disorder, somatic disorder. These are not necessarily all ischemic strokes. It's much more rare. We have about 75 activations of a code stroke at Boston Children's Hospital a year. And again, I only do 4 thrombectomies a year. That's almost exactly the opposite of what it would be like in an adult hospital, where they're doing probably about 400, 500 stroke activations a year, but 90% of them are actual thrombectomies and actual stroke cases to intervene on. I'm going to move past this because I know it's coming up on a break. Where to improve? So I think we can talk about biomarkers. This is going to be absolutely critical for children. If we can identify this in an ambulance on the way to the hospital with just a blood test and something on a chip, then that's going to change the entire workflow, right? Not every child needs to have a brain MRI or a CTA, but this is years down the pathway because right now there's too many different ways that the brain can get injured. So sorting out a stroke versus any other kind of injury is still a challenge. Those key takeaways: lots of stroke mimics in children, but if you see a blockage of the main vessel, the middle cerebral artery, the basilar artery, the internal carotid artery, we have effective strategies to take care of this in children. And it is as effective in children as it is in adults. And it is not more risky in children than it is in adults, even in children as young as about a year of age. We also know that there's a lot of hemorrhagic strokes in children. We talked about AVMs earlier this afternoon, as well as in the morning. Where are we moving in terms of advances? I'm very excited that Boston Children's is kind of leading the way in, for example, vein of Galen malformations. Traditionally, only endovascular people were doing this since the 1980s. But we reported a protocol last year, and then we reported a case this year of successful fetal intervention on a vein of Galen arteriovenous malformation, right? So we directly are intervening on these children who are high risk of decompensation after birth, and doing this prenatally. And this is significantly impacting their recovery and their brain function and development during that critical period just after birth. You know, you may have seen my senior partner, Darren Orbach, talking about this in the international press from this case, and he continues to be actively recruiting patients for this study that's supervised by the FDA and by the the Institutional Review Board as well. And then finally, I just talked about how vein of Galen's are really an endovascular only disease. This is the case I did last week. I think one of the few, certainly there's only about 6 reported in literature of ETVs, endoscopic-driven tracheostomy, which this community is very familiar with for hydrocephalus, but in this case also an ETV on a child who has a vein of velar malformation. And here we perform the standard ETV procedure. We see the mammillary bodies, the basilar artery, and we're going to make a little hole in here so that the cerebral spinal fluid has an alternative flow pathway. Let's get forward. That's our cerebral aqueduct. It's actually open, so it's a little bit more ambiguous why this child is having difficulty with hydrocephalus, except that it's probably a lot of venous congestion from their malformation. We're using a balloon to open up that little hole so that it's wider. And then now we're actually moving through that ETV, making sure that there's clear passage down here. And then what we see here is the particularly novel component of this case, where I'm doing the choroid plexus cauterization. A lot of these vessels are the ones that supply the vein of velar malformation. So they're massive compared to what they're normally at, probably 2 to 3 times the size, even on some of the smaller ones. And you see here, potentially, we can use the cauterization to reduce the flow into the vein of velar malformation. My partner tried to embolize this, and there were too many different arteries to try to block off. And using those little wires and catheters really can't embolize 20 or 30 feeders, because each one of them takes, at least an hour to catheterize, fill with glue, fill with coils. Whereas here I can cauterize a number of these in the order of 20 to 30 minutes. We have yet to see, how this impacts this child beyond the hydrocephalus treatment, but certainly it's kind of an interesting concept of bringing some of the diseases back to the fold, back to neurosurgery, not just leaving this kind of care to our colleagues in radiology. Okay.
I'm sorry, Dr. C, I think we do just have to bring it to an end now.
Yep, please. Actually, that's my last slide.
Perfect. So thank you very much. That was absolutely fascinating, and certainly looking at some of the newer stuff that's coming out. I don't know whether we've got any questions. I can see no questions on the chat. Perhaps you could just stay online for a little while. Oh, we have a raised hand. Hold on, who's raising a hand? Oh, I can't see. There, yes. Nana, please go ahead. Nana, do you still want to ask your question?
I think, Nana, I'll take a look at the Q&A chat, and I can certainly, once it comes through on that, I can certainly pop back on and answer that either on audio or on the chat, depending on kind of the nature of the question. But I can certainly let you all get the next slides going as well. But I'll hang on, wait for your question. Okay, Nana?
Okay, that's lovely. Thank you. And thank you for offering that. So we're actually going to just take a 5-minute break, and we will be back at 3 o'clock when Vicky from the UK, from Bristol in the UK, is going to talk to us about intrathecal baclofen. So just 5 minutes for anybody who needs to gather anything, and we will see you back here in 5 minutes. Thank you. Sorry, my voice really has gone now. So Vicky and Fran, welcome to the ISPN. Vicky is an advanced nurse practitioner in Bristol, and France is one of the specialist physiotherapists there, and they're going to speak to us about intrathecal baclofen. It's over to you.
Thanks, Jenny. So good afternoon. I'm Vicky, as Jenny kindly introduced us, and this is Fran. We're part of the complex movement disorder team here in Bristol, and we're going to talk to you about a new way of delivering baclofen through intrathecal pumps. It's not going to move now. It's not going to move. Oh, yeah. So just a little bit of an overview about our team here in Bristol. The complex movement team also covers botulinum toxin and deep brain stimulation. The ITB service was initially established around 2010 with very few patients involved. We currently have 31 patients in our clientele. The overarching responsibility is with Dr. Todd Smallbone and Dr. Sam Amin, and the team is very much multidisciplinary. We have myself as an advanced nurse practitioner, trainee advanced clinical practitioner, and 3 specialist senior physiotherapists within the complex movement disorder team.
So before we move on to talk a little bit more about pulsatile dosing, we'll just give an overview of what ITB is very briefly. So intrathecal baclofen is the direct administration of baclofen into the intrathecal space, which is the fluid-filled space around the spinal cord. And we can set how we deliver this drug in 3 different modes, which we'll chat about in a minute. So intrathecal baclofen is generally used to treat spasticity of the lower limb and has been used as a treatment of spasticity since the 90s. And there's more and more emerging evidence that it also is helpful in managing dystonia. And the way that baclofen works in general is it mimics the neurotransmitter GABA. And GABA is a neurotransmitter that is inhibitory in nature and plays a role in inhibiting excitatory pathways. Therefore, more GABA equates to less excitatory movement, which contributes to muscle relaxation, helping less spasticity. So just to differentiate a little bit more between spasticity and dystonia, because whilst they're both forms of hypertonia, they are quite different. So spasticity is velocity dependent, and it's normally characterized by a catch and release at some point when moving a limb at speed. And this is secondary to there being lots of hyperexcitability at the muscle stretch reflex at the level of the spinal cord. And one way that we can measure spasticity is using the modified Ashworth scale, or the MAS. Dystonia is not velocity dependent, and it causes involuntary abnormal muscle contractions, which cause really unwanted postures that are normally twisting and repeated in nature. And we often find that dystonic movement is worse with stimuli, whether that's excitatory or painful, and it tends to be synonymous with dysfunction in the basal ganglia. And a way that we can use to measure dystonia is using the Barry-Albright dystonia rating scale.
So I'm just going to talk to you a little bit about method of delivery. So here in Bristol, we've currently got 11 patients using the standardized simple continuous infusion method. This is exactly what it says on the tin. It's an infusion that is constant over a 24-hour period to give a total daily dose. We have quite a few patients, 12 of our patients, on flex dosing. This is where you have a constant base rate, but we're able to increase that amount of baclofen that's given at certain periods during the day. Typically, we find that that is during the morning, very early hours of the morning, and in the evening. So ready for cares for getting up and getting ready for school, and then the bedtime routine. Obviously, we can change that during the day if they've got certain sports or something else going on. And we can alter that times for over weekends as well, when most teenagers are wanting to get up a little bit later. On to pulsatile dosing, what we actually mean by that. So this is when you program in a very low background or base rate as a continuous infusion. We then put 6 pulsatile doses, 4 hours apart, onto the programmer, and we give that bolus dose over a 5, 10 or 15 minute period, depending on how large that bolus is. When we increase the overall daily dose, we put extra onto each of those peak pulsatile doses rather than onto the base rate, to then give us our overall daily increase. So we've been using this method on 6 patients. We have used that for patients with dystonia as their primary symptom. And then we've got a couple of other patients that we've tried this as other methods have just not really yielded any satisfactory results for them. So we currently have 8 patients on our pulsatile dosing regime. 2 were initiated from pump implantation, And then we converted 6 from either simple continuous or flex dosing. So when we are converting children from the other method of delivery, we then have to take off 10 to 20% of the overall daily rate, and we put those onto the 6 pulsatile doses. Each time we want to change the pulse rate, we will take a further 10 or 20% and put that onto the pulses, so that eventually you have a very low basal rate and then higher pulsatile rate 4 hours apart.
So of our 8 patients that are on our pulsatile regime, 5 of them have been on this regime for over 12 months. And out of interest, all of these patients have been put onto pulsatile dosing for managing their dystonia. So we've collected a quality of life outcome measure, the CP child score, and compared this data to pre-pulsatile dosing and post-pulsatile dosing. And as you can see, out of those 5 patients, 4 have had improvements in that quality of life measure. And it's important to remember that with this patient group, even the slightest increase in quality of life can mean a really, really successful outcome and big change to that patient and family. And then I'm aware that we're missing one set of data here, but looking at their dystonia using the BAD, the BAD is scaled by 0, meaning there's no dystonia, and 4, meaning it could be the most severe dystonia. It's quite a crude measure, but does give us a bit of an idea about how their dystonia has changed. So I've highlighted the most significant changes in yellow, and we can see really significant positive changes in 3 of those patients. So from it going to quite severe to mild or slight. And in one patient that I haven't highlighted anything for, they still have had some good changes, but otherwise it has been static, which is also can be seen as quite a good thing, as the dystonia hasn't got any worse. So the data we've collected doesn't show the full picture, and we get lots of really nice subjective feedback from parents and caregivers when they come for refill appointments. But this is something that we are collecting more and more data from the more that we're using this, and something that we want to look at more is the number of hospital admissions, whether this is reduced since we started the pulsatile regime, whether their rescue medications have changed and whether that's reduced. And we also want to get some more quality of life and psychosocial outcome measures for this bit of work.
So I thought we would look at a case study, a patient that we learned a lot about how not to do things really with pulsatile dosing with. So we had a young man admitted in status dystonicus. He was ventilated and stated on PICU for quite a long time. DBS wasn't an option. He's got cochlear implants in situ. So we couldn't really scan him from an MRI perspective. So the next thing that we could use was intrathecal baclofen. He was dosed with that, with bolus doses, and had really good response. So he went straight to intrathecal baclofen pump insertion, and was immediately commenced on pulsatile dosing. We used our usual standard 1,000 microgram in a ml concentration to start that infusion. Over the next couple of weeks, we increased his pulses really quickly to a reasonably high overall dose. This really improved his dystonia, significantly reduced his dystonia to the point where he was extubated and had quite a lot of his sedative infusions reduced quite considerably. However, this is where we realised our mistake in starting with our usual regime. When we changed straight to 3,000 micrograms in a ml, which we no longer use, we only use 2,000 as our maximum now here in Bristol. We realised that concentration change, of course, for those of you in the know, meant that we had to put a bridge bolus in. Bridge boluses, unfortunately, are a simple continuous infusion. They don't give any of those pulses. within the 4-hour window, maybe 6 hours in, our patient deteriorated quite considerably on a simple continuous infusion, to the point that he required further intravenous sedatives and some non-invasive ventilation once again. Once that period of bridge bolus had completed, 4 hours after that, and the pulses came back in, within 24 hours, he returned back to where he was with his dystonia. And he's been stable pretty much all the way since. And we've got to be probably 14, 15 months down the line now with him. He's in great shape.
So in conclusion, we have had some really great results from pulsatile dosing, but we have got a very small number of patients that are under this regime, and we, can't use all of our research that we've gathered and assume that that's going to be able to be generalized to everyone. We have found that there's been a select group of patients that have benefited from pulsatile dosing, so those that are dystonic and those that spasticity has been really challenging to manage on a simple continuous and a flex dose. But we definitely are aware that there is more and more research and data that we need to gather.
Yes, absolutely. We know that the evidence is sparse for this. In fact, there is no evidence. The only reason that we started to consider and then commence pulsatile dosing was word of mouth through the English ITB forum, lots of discussion. There were some other consultants, especially within adult services, using this type of regime with their patients. What it has meant is we have developed a standard practice guideline, which means that there is consistency in the approach that all of us within the team take to these children when we are starting their pulsatile regime, whether that be from a simple continuous infusion down to a pulsatile dose, or whether we're initiating that pump implantation. Ultimately, when we have more patients, we'd like to publish this information so that it can be used for others, because anecdotally, through parents, we definitely have had quite a marked improvement with some of our patients. So that's it. It's a bit of a whistle-stop tour, but have you guys got any questions for us?
That was really fascinating. Thank you, Vicky. I'm sorry for my squeaky voice. I have a question for you. Who else is using it in the UK or around the world?
Well, interestingly, I went to an ITV forum on Friday, and I think pulsatile dosing is becoming more used in the UK. So I think in the London hospitals, they're using it, and it's being quite well used in the adult ITB population, I think, across the UK, with Liverpool using it quite a lot, Nottingham as well. So I think it's definitely an emerging thing, but within pediatrics, I think it might be Bristol probably have the highest caseload, followed by London.
Okay. And is it being used elsewhere in the world?
I'm not sure about that, actually.
Okay. Let me see. We got no other questions on there at the moment. So thank you very much for that. That was really fascinating. It's certainly something I'll be taking away. And it's great to see you guys in Bristol.
Lovely to see you too.
Please hang around. Somebody may put a question up. But for now, we're going to move on to Brazil. Thank you, Vicky. Where Dia Neves, I hope I've said that correctly, Dia, is going to talk to us about the nursing care to children in the post-operative period of PVD, the experience of a neurosurgery service in Rio de Janeiro. Dia, are you with us? She is.
Good afternoon. It's a pleasure to be here today to talk about your nursing practice for children with PVD at the Fernandes Figueira Institute, Fiocruz. My name is Dea, pediatric surgery nursing. I am responsible for ward management. In today's presentation, I'd like to show you what is the peritoneal ventricular shunt, its purpose, and explain to you how we do it in our institutes.
One second, please.
Peritoneal ventricular shunt, PVG. Concept. It is a system used in the treatment of hydrocephalus and in the relief of intraventricular hypertension caused by them. Intracranial hypertension will lead to increase in the size of the ventricles causing impairment of brain function, such as visual difficulty of learning and delayed neurological development. Pediatric surgery ward profiling. Our institutes welcome children for all over the states and even from Brazil throughout the regulation of SUS vacancies. Last year, we had an average of 29 cases of PVG. Profile, children and adolescents aged 0 to 70 years with surgical pathology. Number of beds, total 12 beds. Neurosurgery patients, 3 beds. Follow-up is with a multidisciplinary team. Average length of hospital stay, 2 days. The family stays present during hospitalization. The self-hospital is programmed with inputs if necessary. Nursing care for children in the postoperative period of PVG. Keep the beside at 0 for the first 6 hours after the procedure. Increase to 15 degrees for the next 6 hours. Increase to 30 degrees after the first 24 hours if the child tolerates it. Monitor the child with pulse oximeter. Check and register 6 hours vital sign and urine outputs. Install fluid balance until suspension of intravenous hydration. Keep an eye out for signs of mechanical complication, disconnection, obstruction, and closing. Identify signs and symptoms of underdrainage, increased ECP. Observe nausea, vomit, apnea, bradycardia, irritability, and seizures. Observe tight production, fontanelle, engorgement of scalp veins. Observe sensitivity to light and other visual disturbance. Reintroduce oral feeding after a well-canned shield. Hospital discharge of children who used PVG. Wound care guideline at home. Dressing with saline solution, 0 9. And dry well. Keep dressing open, dry and clean. Return in 15 days for evolution and removal of sticks at the neurosurgery outpatient clinic. It is usually a simple surgery with no complication. Reference. So that is the thanks.
Dear, thank you. Thank you so much for your presentation. And thank you for presenting it in English. You did a fabulous job. You should be very proud of yourself. Thank you. Following that, we will have our last. We'll have our last one, which is from Leali. Leali?
Yes.
I hope I pronounced that right. I'm so sorry. I hope you can understand me. Shlomi has joined us in the room.
Great.
And is going to listen to you as part of your.
In my heart all the time, even if he's not there.
Lily is going to speak to us on the necessity for a unique training program for pediatric nurses in treating non-oncological terminally ill children. That sounds fascinating. I look forward to hearing it. Over to you.
Hello, everybody. My name is Leali, as it says, and I'm from Israel. As many of you know, there is a war taking place in my country. So it may be possible you will hear some sirens in the background. Hopefully everything will be okay. So let's start. Hi, my name is Leali. I'm a nurse in the Pediatric neurosurgical department for 15 years now. I work at Tel Aviv Medical Center in Israel. I would like to present my work about postoperative care for hospitalized terminal ill child. First, I would like to introduce my department. We were founded in 1996, and since then we are the largest pediatric neurosurgical center in Israel, under the direction of Professor Roth and Professor Constantini. Our patients come from all over the country and the world. We treat around 2,500 children a year, with over 450 surgeries a year. Here we can see the list of some of our specialized oncology, congenital disorder, vascular disorder, endoscopic surgeries, and the list goes on. The next slides show the number of children who died in our hospital in the following years. On average, 14 cases a year, although most of the deaths are in the oncological department and the intensive care units. Deaths in our department are rare but still exist. In our daily work, we are exposed to complicated stories and critical ill children. For me, in every one of these situations, I want to believe this will be the most difficult case. But unfortunately, the reality is different, and the limits are stretched every time over and over again. After such an introduction, I would like to present the case that drove me to conduct this study. Noah was born to young and healthy parents and 3-year-old brother at home. Her mother had a car accident in the 20 weeks of pregnancy, which led to a premature birth. Noah was born at 28 weeks, weighed 1.2 kilograms, with a wide range of problems: low Apgar, difficult breathing, hypotonia, Klebsiella meningitis. A postnatal brain ultrasound demonstrated a grade 3 intravascular hemorrhage and multiple brain cysts. Later, an MRI showed a significant enlargement of the ventricles and contaminated hemorrhage and multiple brain cysts. At the age of 4 months, there was significant increase in the head circumference a great difference in mobility, worsening neurosurgical status, vomiting, and inability to eat. Here you can see the brain MRI at the age of 4 and 5 months. You can see the worsening volume and number of brain cysts. NOAA cases was presented in several multidisciplinary forms and non-operative management was decided. Therefore, when her condition stabilized, she was discharged home from NICU. To note, already in the early stage of her life, conversations were held between the parents and their care team, in which was explained that we have minimal option to offer, but we will do everything to ease her suffering. Despite this conversation and discussion, upon her next hospitalized, when her situation worsened, her parents insist to perform an operation, and an endoscopic draining of the cyst was conducted in order to relieve no suffering. She was discharged home and returned a week later with an infection and CSF linked from the surgical wound. At that point, after long discussion and in light of poor prognosis, it was decided to adopt suppurative treatment only. After 2 weeks of hospitalization in our ward, Noah died when she was only 7 months old. During Noah treatment, we discovered several shortcomings and lack of knowledge of treating staff regarding palliative care in neurosurgical department. As a result, we realized that it was necessary to evaluate and act in order to improve the points of weaknesses that we identified during NOAA treatment. In the left column, you can see the points we identified as problematic in our management of the case, compared to the right column, where you can see the principle of palliative care we should strive to reach. In light of the findings, we built a pilot study. Our aim was to investigate the difference between the oncological nurses and nurses from other pediatric wards in terms of skill and knowledge regarding suppurative care for terminal ill children, as well as comparing answers between 2017 to 2023. Our study population includes nurses from all our children's hospitals wards, and 32 out of 220 nurses were from the oncological wards. Here you can see the full questionnaire that includes knowledge and attitude questions regarding palliative care. For example, in your option, should all nurses receive training in this area? We hypothesize that relationship exists between the type of pediatric ward and whether a nurse feels she has received sufficient training in end-of-life care. Treating a terminal ill child is not unique to oncological ward nurses. There is need for professional training and guidance when dealing with a terminal ill child. Perception and need for guidance in palliative care in 2023 will be more positive compared to 2017 due to an increase in available resources in the field. We used the same questionnaire in both years. In 2023, we had more precipitation, but both groups had equal representation for all wards. All comparisons were between the groups of oncological nurses compared to the groups of other ward nurses. About 90% of the respondents have reported treating a terminal ill child during their work. However, there was a significant difference between the groups. Almost all the respondents believe a terminal ill child should be treated different than other hospitalized children without difference between the groups. Only about half of the respondents were aware that hospital has palliative care team, and only 22% were trained in palliative care during the last 4 years, with high rates within oncological nurses. Those who have completed the program reported it to be quite beneficial. When comparing the years, same rates of nurses responded feeling the need to have professional guidance when treating a terminal ill child, and also same rates of nurses responded they believe every nurse should undergo a training in a treatment of terminal ill child. In this slide, you can see the comparison between the groups and also between the years regarding the question, do you feel you have enough tools to take care of terminal ill child? When we examine the chart, it becomes evident that the situation today is even less optimistic compared to 2017 in the both groups. Overall, less than 20% of 2023 questionnaire responded believe they have the resources necessary to care for terminal ill child. Regarding the question, have you been given guidance for the care of terminal ill child and his family? We can observe the slight rise in both departments in 2023. This indicated that more individuals have gained and knowledge over the years in providing care for sick children and their family. In conclusion, we found no relationship between the type of pediatric ward, whether a nurse feels she has received sufficient training in end-of-life care. Treating a terminal ill child is not unique to oncological ward nurses. There is need for professional training and guidance when dealing in a terminal ill child. And in contrast to our hypothesis, there was no change in perception and need for guidance in palliative care in 2023 compared to 2017. We found also that treating it in the field of palliative care should be provided not only oncological ward nurses. Awareness and guidance regarding hospital resources in palliative care should be increased. Following these studies' findings, we have contacted the special pediatric palliative team aimed to provide guidance and support to nurses treating hospitalized terminal ill children. The first step will be a pilot in the oncological ward, and the second step will be support all the pediatric wards. To end with some inspiration, Cecilia Saunders was the founder of the hospice movement. She was a social worker and a nurse, and in order to establish the first hospice, she also completed medical studies. In 1967, the first hospice was established with the philosophy that you matter because you are you, and you matter to the last moment of your life. Hug your children. Thank you very much.
Ali, that was a beautiful presentation. Thank you so much. And I think it's hugely relevant to all of the neurosurgical nurses around the world where we deal with patients who unfortunately are on a palliative care plan. So thank you for bringing that to us. And you know, we all hope you remain safe where you are in your times of trouble at the moment. And we stand with you.
Thank you very much.
So for that, I believe that's going to bring us to the end of our day today. I would like to thank everybody who has contributed today, because there's been an amazing sharing of information of what people are doing in various places. And it's just really good to see everybody here presenting. We've had most of the day, we've had between 35 and 50 people listening. So we've reached out across the world to many, many different spaces. So I'm very grateful to everybody who has contributed, who has spoken today.
Sorry.
And I'm very grateful to everybody for listening. We did say at the beginning of the day, if you remember, that we were going to give out an award for the best presentation. And the person who gets the best presentation will have a nice certificate sent to them online. And also will be able to register to come to the ISPN next year in Toronto, and they'll be able to register for free. And I'm really pleased to say that we've had a discussion with those of us who are in the room, and we would like to award it to Allison Allison Da Silva from Brazil. Allison, you gave two really good talks again today. It was the second one of your complex fetal myelomeningoceles that we felt specifically was really, really good. So many congratulations to you and thank you for being part of the day. And we look forward to seeing you in the room next year.
Thank you so much. See you next year.
See you next year. Thank you so much.
Thank you.
And goodbye to everybody else.